Good morning. If everyone can take their seats, make themselves comfortable for this amazing event that we have planned for you today. My name is Susan Elliott. I'm a professor of medical geography here at the University of Waterloo. My pleasure to welcome you to this amazing event and this amazing symposium day. I also just want to explain to you, I heard some people asking the question about why is there a goose on the keychain that everybody got, and what does that have to do with the University of Waterloo? If you can go into a university bookstore and buy a t-shirt that says, "I survived nesting season at the University of Waterloo," you will understand why there is a goose on your keychain. You will also understand that if you go out for a walk on this beautiful day, if you see geese coming towards you, go the other way. It's my tremendous pleasure to introduce our President and Vice Chancellor, Dr. Vivek Goel, to welcome you today.
Thank you, Susan. It's my pleasure to welcome everyone to the University of Waterloo Research Symposium, Health and Wellbeing for All by 2030, to discuss the application of technology to solve global health challenges. Before we begin, it is important to reflect and acknowledge the University of Waterloo's campuses in Waterloo, Kitchener, and Cambridge are situated on the Haldimand Tract, land 6 miles on each side of the Grand River, granted to the Haudenosaunee of 6 nations. The land inside and surrounding the Haldimand Tract, including our Stratford campus, is the traditional territory of the Attawandaron, Anishinaabe, and Haudenosaunee. I also acknowledge and recognize this area is now home to many diverse First Nation, Inuit, and Métis peoples. In a moment, we will hear from our elders who will provide us with some important context about the traditional territory upon which many of us here are fortunate to live and work. This includes Elder Henry, who is one of our Indigenous elders here at the University of Waterloo, who's supporting our work towards reconciliation. And in particular, he works in our Faculty of Health and helps to build reciprocal and respectful relationships with Indigenous individuals and communities. I'd also like to reflect that we know the journey to reconciliation is a long one, and there is going to be much, much difficult work to be done. But there are everyday things that each of us can take on that may be small steps on that long journey. And I'd like to reflect on an example I learned about a few weeks ago. One of our students in optometry, Jeremiah Hislop. As a first-year Indigenous optometry student, he joined one of his reasons for going into healthcare was because he'd seen the challenges and the discrimination that his family and his community faced in the healthcare system. He wanted to work to address that. In his early clinical training courses, he came across the iCard used for reading. You probably all had experience with them. And he noticed that some of the phrases in that iCard, which probably hadn't been revised in 60 or 70 years, were racist or could be seen to be racist. He didn't just take that. He talked with his professors, he talked with Elder Henry. They went to visit the company that manufactures these cards that are distributed right across the United States and Canada, and they got them changed. And that's one small step that anyone can help to drive on the journey to reconciliation. So we're honored to host the Royal Society of Canada's annual celebration of excellence and engagement events on our campus this week. Today's event, you're going to hear from many researchers and speakers about the convergence of transformative research, experiential education, and entrepreneurship, and how they can help us address our complex health challenges. We often talk about innovation in healthcare. The reality is we are innovating every day. Sometimes we have disruptive innovations, new drugs, new imaging technologies, but more often we work with incremental innovations. And today we'll talk a lot about technology innovations, but we can have social innovations, as just like the example I gave you, kind of policy innovations, business process innovations. One thing that is very clear is we cannot continue to do what we've always done with healthcare. It is simply not sustainable here in Canada or anywhere in the world if we continue to deliver services in the way in which we've always done so. And so it is essential that we engage in the kinds of conversations that we're doing today. So I'd just like to close by thanking all of you for taking the time to join us. I'd like to thank the moderators, the panelists and speakers, and particularly our keynote, Stephanie Nolan, that we'll hear from very soon. And at this time, I would like to invite Elder Mayangan Henry and Elder Bonnie Whitlow to come up to deliver the Indigenous blessing.
Sego sewa goego. Hello, everyone. Goanago niyong yats. My Ungwahue name is Goanago. It means that the gift that I carry is in my words, it's in my language, and it's in my voice. Wakskarlewage. I'm Bear Clan. Oswego Nidwagenu. I'm from Six Nations. Ganyak Gehagani Wagun Hunjoda, and I'm Mohawk. Luana Hudges Luayat Nairliaa. I have a son, his name is Luana Hudges, and he doesn't have an English name. And that's one of my assertions of sovereignty that I went after at that time because we no longer had to have an English name. And so I'm really proud of that. I'm thankful to be invited here today to help out and to provide what's called the Ohandagali Wadekwa, which is the law of the land for us as Haudenosaunee. And a lot of people will call it a prayer or a blessing. I tend to not think of it that way. I've come to think of it more as like a guided meditation and a reminder to all of us as human beings that this is a practice that we continue, and it's the law of the land for the Haudenosaunee, that whenever more than 3 people gather together in a room, our first responsibility and our only responsibility as human beings that was given to us at the time of creation when Earth was seeded with life, the only responsibility we had was to remember to be thankful to the entirety of the natural world and to remember all of those duties that it performs to take care of us. And I liken it to when those people in feminism speak about the invisible labor of women, we speak about the invisible labor of the natural world and how it sustains everything we do and everything we are so that human beings may flourish. Everything comes from the natural world, from the clothing we wear and the glasses we wear to the chairs we're sitting on, to the technology that we're using. All of those things are being provided to us constantly. And so in my community of Six Nations and in our other Haudenosaunee communities, we do this regularly and repetitiously and habitually all the time. We take a moment before we get to the business at hand, and we remind each other to be thankful. So I've tried to develop this, and I try to pop into the language and out of the language. It's a bit of mental acrobatics, and I kind of know where I'm going, but I don't always know where I'm going, and I'm a second language learner. It's one of those things that I really went after hard. Instead of going after a PhD, I went after the cultural teachings, and I went after the recovery and revitalization of my cultural legacy, part of which is being able to speak Ganyot Geha. It's probably that accomplishment that I'm most proud of. And for us, the ability to do this is an honor, and it's said that we stand up so that we can be seen by Creator. And so I'm going to put through these words, and I'm going to try and bring you along with me. I might not get translations done because I have to do it so quickly. And at home, this takes like an hour. And here we got, I don't know, 10 minutes? So I'll try my best. Ganjoko de waduhusios chinigaliwes de chida wanulados nesangwai disu 100 galiwa dekwa idwa wano hetste. So that is just a call out to the people in the room that you set everything aside, you put down your phones and you listen really carefully to the words and you try to visualize in your head the things that we're talking about, because that's the Skatnigula, that's the one mind that we're trying to achieve. And that's the gift that we're going to leave behind. Ona nua non chida wade ni go laerde gio hanjade dano dietinu lados a guego neneo hanjagessa dietinu lados ne chisego yunki at the hosta no yunki at the na genio tachi la werlo na segwai dis on genio tachi logo dagwal dano lowe na da o gio hanjade gio das way gio hanjade dietinu lados ne chisego lodio daje genio tachi logo dagwa genio tachi sagali nayani Negadi nue the watkoe neganula do salai tony and do hak neum got nigola. So that first one I asked us to take our minds and to turn towards all of those things that are earthbound, all of those entities that continue to fulfill their responsibilities. I have a difficulty with one of these translations because sometimes we use it to almost mean like a contract, but it's not a contract, but it is a contract. And what it says is that when these things were created, the plant life, the animal life, the waters, all the things, the life-sustaining pieces, the roots, the bugs, the trees, everything has a responsibility that's attached to it, and all of these are the things that will create stronger minds and stronger bodies. And this is well-being, health and well-being. And this practice for us is to remember that everything that helps the human being flourish is in the natural world. And if we can remember our relationship to them, then we can find a way that all people, like all the different types of people, can flourish alongside of all of the natural world. And together, it's like a family, it's a kinship that's created. So we take our minds, we turn towards all of those earthbound entities, and we leave behind this gift for them, this thankfulness and this gratitude. And that's how our minds will become one. Onanua, jitkalon hiade non chitavate nigo laerliti, danu dietino lados aguego nene lodi satstan soloanos, aguego Gina Hodason, Sego Yunkiat the Gahasta, no Yunkiat the Nuna, ne Ungwait Sun, a Johonjade, Dietino Lados, ne Gisego, Azeon Sununi, Gahnegalunya, Dano G. Yohanjade, Dietino Lados, ne Gisego, Yunkiat the Nuna. On a new and on Chidwade Ningo Laerlite, Jit Galunhia, de Dano Dietino Lados, ne Galunhia Gasu. So with that one, I asked our group that has been assembled to turn their minds towards the life forces. Translations are difficult. Okay. Deatinur lados ne galuhiagasu. They are the beings that create or help to sustain life on Earth. And they continue to reinvigorate the waters and the lands. They continue to come in and pick up those things that can be harmful to the human being, and they can pick them up and they can take them away from the humans and put them where there's no human beings living. So again, we bundle our minds together and we take that gift and we place it before them. And it's also like we use their names so that they know that we're talking to them and we're leaving this gift behind before them. Onanua isina garluhia di nanchi the wade ni go early day dano the chidwanu lados ne songwai diuso yawes g lo tundes g sego de watsta ne ungoana dano de wasolas gini angwali hodos ayar like g sego sungwanar lunkwa ne g ago gina hodaso lo ena da jo de sego lo dio daje ginue sagotalo. Yeah, so with that one, I asked us to take a moment and to turn our minds towards, it's what's called the other side of the sky, where he chose to live, our Creator, and that he would hear that the human beings he placed in this part of the world, the Ungwahumwe, the indigenous people of these lands, that we continue to use the language that he gave to us, and that we're fortunate that we still have it, and that we continue to follow the practices that were set down for us, because those are the practices that are going to sustain human beings, especially in this world that we're looking at right now. Dogadatano sunget ni gorha ajiza wa datso ajiza wa godago neo handagali wadekwa ne ti wa gadala kweni negadi nue adawatwe neganula de sola etoni ndu hak ne ngwat nigola. So the last one is just that I was happy to be invited, and thank you for asking me to put through these words, and that if I have forgotten anything at all, then I ask you all here to make it right in your minds, and that together, that's how we would cover our human responsibility. So, thank you very much.
Bujo, you know, those are very beautiful words, Bonnie, and I really appreciate bringing that to this audience today, because we're on a path today. We're trying to find ways of building relationships, and you know, our history hasn't always been beautiful in this country. We've seen residential schools, we've seen 60 Scoop and various murdered and missing women throughout our history. But with all that said, without being having a chance to share knowledge and to walk this path, we'll find reconciliation if that's the goal. But it's going to take all sides to work on this together so that we can find this path together. So today, at this university, I'm very proud to say that we've been honored with a commitment that means so much to the future generations of all people that live in Turtle Island. It's a matter of building this relationship so that we can have sustainable futures and even identifiable, healthier relations with our beautiful Mother, the Earth, which is the foundation of all that we exist for, building that relationship with all that Creator gave us, and to walk this path with the responsibilities that were given to each and every individual plant, animal, and water, to take care of the things necessary so that our future generations will thrive and have the abundance of love, honor, and respect that is embedded within the love Creator gave us. So today was about a year after we had a commitment ceremony at the university. We decided to honor the university with an eagle staff. And Jade is holding the Eagle Staff today, which we bring to different functions at the university and outwardly. When I travel throughout different communities, I'll take the Eagle Staff and represent our university with the Eagle Staff at powwows and other gatherings. So with that said, we will have an opportunity to share our goals together around the world. And so with the Eagle Staff being held in the way it is, it's usually somebody of great, honor to carry the Eagle Staff. And Jade is such an honorable person, and we really love having you here. And to hold the Eagle Staff today, it's an honor to watch. And so I'm going to offer you a quick song, which will be a part of our relationship with this world and creators, all our relatives in Creators World. Before we do our song, we usually take one of our medicines, which we call, in my language, mashko de wishk. And we take and we smudge our instruments. We smudge ourselves, which is our connection with, I guess you can say, the teachings that our elders have always given us. If we look at our mashko de wishk, our sage, I guess we can call it in English, it reflects the elders and the teachings. If you look at it, it's kind of gray, just like an elder's hair. And the smell of it is kind of strong a little bit, because they say when an elder gets to that stage and they're a little closer to Creator's World, they know they have to have a strong teaching, because they know at some point Creator's going to call them back home. And so when you smell that, you can tell that it's being used, and the elders are presenting the wisdom that will be a legacy that they teach future generations to come. So we use our medicine when we wash our sacred items, and we cleanse ourselves every day to be able to feel that beautiful honor of the teaching of elders. And I guess you can say, if you see a flag, a Canadian flag, it would be like a symbol of the nation. In the Indigenous world, we do carry symbols like our Eagle Staffs, which is a symbol that we would stand for at any event, because it represents various things, but nations are a huge part of what the Eagle Staff carries in its heart. So we'll offer this kind of like I guess, in old Canada, I guess, but in our way, it's honoring our ancestors, because they are the ones who gave us the inspiration to do this. So if you don't mind, and if you can't, I wouldn't mind if you could stand up for a second, and we'll honor this Eagle Staff today. Hey ya hey hi ya way ya hey ya hey way ya hey ya hey ha way ya hey ya hey ya ho hey hi ya hey ya ho hey way I hi yo way I hi ya hey ya hey ya ho hey way ya hey hi ya way ya hey ya hey way ya hey ya hey ha way ya hey ya hey ya ho hey hi ya hey ya ho hey way I hi yo way I hi ya hey ya hey ya ho hey way ya hey hi ya hey ya hey ya hey way ya hey ya hey ha way ya hey ya hey ya ho hey hi ya hey ya ho hey way I hi yo way I hi ya hey ya hey ya ho hey. And we'll save the last verse. They say that when we're born in this world, Creator gives us a heartbeat. And inside your mother's womb, you carry that heartbeat to walk this earth with. And they say that over time, when we reach that western direction, that's when Creator might decide to take that heartbeat away and move us back to the spiritual world that Creator has for us all. And so the last verse of this song, we don't use the drum because it's a representative of the heartbeat in our mother, the earth. And so what we'll do is we'll honor all those ancestors that have moved on to Creator's world, all your loved ones, all your grandparents and parents and loved ones that you have that are in Creator's world. We give them that moment because they still inspire us. They still help us become who we are in this world, and we still love them so much. But we know that Creator's taking good care of them up in Creator's world, so we give them this part of the song. Way-ya, hey-ya, hey, hi-ya, way-ya, hey-ya, hey-yo, way-ya, hey-ya, hey-ha, way-ya, hey-ya, hey-ya, ho, hey, hi-ya, hey-ya, ho, hey, way-I-hi-yo, way-I-hi-ya, hey-ya, hey-ya, ho, hey, way-ya, hey-ya, hey-yo. Abujo maingan in dejnakas deshkan zibi and donjiba, maingan dodem, get your manado, chimigwech minwaka kina manda, ganaj when giz get nongum. Get your manado, chimigwech minwaka kana wasiak mampi, get ye ni John Sanonic. Get your manado, chimigwech minwaka kina mage, wabanung zawanung, epping nishmuk, kiwadenung. Get your manado, chimigwech minwaka kina mashkiki, o sama wingash, mashko de wish minwijik. So in that song to our ancestors and the prayer to all beings on this earth, we welcome you and we hope you have a great day, and we'd love to get to know you more, and hope your experience here at the university is wonderful as we feel. We are so lucky to be together today. Miigwech, everybody.
That was such a beautiful way to start our day. And as a global health researcher myself, I am incredibly honored and proud to introduce our keynote speaker, the first keynote speaker of this morning, which is Stephanie Nolan. She is the global health reporter for the New York Times, a veteran foreign correspondent who's reported from more than 80 countries around the world. She is an 8-time winner of Canada's National Newspaper Award and a 7-time winner of the Amnesty International Media Award for her coverage. She's the author of 28 Stories of AIDS in Africa. That was my first introduction to Stephanie, just a fabulous book if you haven't had a chance to read it. And that book won the PEN Courage Prize. She also authored Shakespeare's Face and Promised the Moon, the untold story of the first women in the space race. She served as bureau chief for Canada's Globe and Mail in South Asia, Africa, and Latin America. And she has a passion for building innovative, immersive digital storytelling projects. She's an experienced public speaker with a focus on public health, gender equity, and social inclusion. So a perfect addition to our day today. She was the 2021 Atkinson Fellow on Public Policy, writing about the COVID-19 pandemic and inequity. Ladies and gentlemen, Stephanie Nolan.
Thanks so much. Okay, it's a long walk. Yeah, thanks. Good morning, everyone. See, I was worried about that microphone crinkle. I'll do my best to not crinkle. It's such a pleasure to be here. Let me say, first of all, thank you to Elder Henry and your supporters. That was really lovely, and I'm particularly really enjoyed hearing from Bonnie, and as a person who's perpetually trying to learn another language, I have such admiration for someone who does in the moment translation and tries to translate ideas that really clearly are difficult to mash into a language that isn't necessarily structured to take them on board. I love that idea of the other side of the sky, so I really appreciated that. Thank you. Thank you also for the invitation to be here to talk to you. I'm very conscious as I look out at this room that obviously this relationship is usually reversed. I'm usually phoning you because I want to know things from you. And so I hope that there's a few things that I can tell you that will be useful. There we go, okay. I, as you just heard, spent the best part of 25 years as a foreign correspondent. And as a correspondent, you kind of have to cover everything in the place where you are, right? So it's politics, economics, social issues. Because I was based primarily in the Global South, or well, actually always as a correspondent in the Global South, inevitably health was a big part of what I was writing about. And that was most true in sub-Saharan Africa when I lived there at the height of the HIV pandemic, and I really just wrote about HIV, not exclusively, but it was impossible to live in that environment and not be telling stories that were health stories because the political and the economic and the social stories were health stories. And that was true in South Asia and Latin America as well. And then I moved into this job as the global health reporter for the New York Times a few years ago, and the Times is one of the last organizations. I'm a global health coverage team of one, but the Times is one of the last media institutions that has someone focused on global health at all. And people think that that means, you know, diseases and cures, right? But actually what I write about most of the time is systems and structures and access and equity and who gets access and who doesn't and why is that. So I'm a full-time health reporter now, but actually I'm writing about politics and economics and societies. And in this job, I talk to people in different parts of the world every day. I have the privilege of traveling a great deal. I've made 6 big reporting trips this year to sub-Saharan Africa and Latin America. I'm on my way. At the end of this week, I was supposed to be going to India, but there's obviously a small problem for a Canadian reporter trying to go to India at the moment. But I'm hopeful that'll happen, and to Southeast Asia. And so I have the opportunity, the luxury of talking to people in all of these places, which I think gives me a bit of maybe an unusual perspective, and I hope that I can draw on some of that and tell you some things that are useful to you today about what I think about this question of health for all and how we're going to get there. And I'd like to start by telling you a story. It's a story that takes place here. So this is a little outpatient clinic in Accra, in a low-income neighborhood on the edge of Accra, the capital of Ghana. It's called the Kineshi Polyclinic. And I found myself there. Actually, I spent much of the day in that white plastic chair in July. And the reason that I was there, this is very unusual. So I was there, this is the tuberculosis clinic at Kineshi. And I was there because I almost never in 30 years of writing about global health have had cause to say this, but I was there because there was a lot of good news, which I was there particularly to write about tuberculosis. And this kind of really interesting thing has been happening in tuberculosis that I will recap for any of you who haven't been closely following the world of tuberculosis. After kind of so TB, still a fully treatable, curable illness that has retaken the title from COVID-19 as the deadliest infectious disease. It killed 1.3 million people last year, despite being fully treatable. And decades went by there where we didn't really move the needle on TB at all. And all of a sudden, in the past couple of years, a whole bunch of things that have happened that make eliminating tuberculosis a lot more possible. It's like certainly possible to think about how we might get there. And the first of those is improvement in treatment. And so for again, folks who may not know as much about TB, treatment for either drug-resistant or drug-susceptible tuberculosis, it's terrible. It's like freaking terrible. I believe that's the professional medical term. It's up until very recently, it was somewhere between a year, 18 months, 2 years of drugs, not one drug, but like fistfuls of pills every day. If you're treating drug-resistant tuberculosis, you could be looking at taking 14,000 pills in the course of your treatment. They're horrible drugs. They had terrible side effects, including permanent hearing loss, psychiatric disorders, bone pain. So I've had TB patients tell me, like, dying of TB, really bad, but like, sometimes feels questionable whether dying of TB might be preferable to actually taking TB treatment. So of course, if treatment is this bad, people don't want to take it and they don't stay on it. They have trouble adhering to the drugs. You get more drug-resistant tuberculosis. You get the disease being spread through people's communities. Tuberculosis treatment was terrible. Very recently, the last couple of years, and in fact, yesterday morning in Paris, some new clinical trial results about better and better drug combinations that people can take for shorter and shorter periods of time that don't have this side effect profile, that really increase the possibility that people are going to stay on the drugs. Also super important, they've become a lot more affordable. Advocacy by people living with TB, organizations like Doctors Without Borders and Partners in Health that care for those people, they've helped bring the prices of those drugs down so that they're accessible to a lot more people. Also, a thing we haven't had is good preventive therapy to help protect people who live with somebody who's diagnosed with tuberculosis. That also has become more accessible, more effective, a less onerous drug burden in the last little while. The next thing that's happened is in the world of vaccines. So we have one vaccine for tuberculosis currently. It's called BCG. We give it to infants. It's quite protective in infants. It's not great. It's not much use at all for adolescents and adults. That's a problem because 90% of the TB burden globally, transmission, happens among adolescents and adults, not infants. That vaccine is more than 100 years old, and there was nothing new in the world of vaccination until very recently. And all of a sudden, we have TB vaccine candidates. We have one in phase 3 trials it has really good efficacy. It has a great safety profile. People are really excited about that vaccine and getting it to people soon. But there are 6 more very promising looking TB vaccine candidates in the pipeline. And for people who don't work in the world of vaccine research and TB vaccine research, that's like if I say to you, I have this unicorn, look at this thing. And by the way, if you don't like this unicorn, I have 6 more unicorns out back, right? Like this is like a huge shift in how we talk about TB vaccination. So like again, people are not often really excited about things like this in my world, so it's really nice to hear from these people. There's also been a big shift in how we diagnose tuberculosis. So again, for more than 100 years, we did the same thing. We looked at a sputum sample from someone with TB under a microscope, or if that wasn't available, it was x-rays or clinical symptoms, and that was not very reliable. Now we can diagnose with TB with a PCR test, just like we did for COVID. And as a silver lining of COVID, the machines that do that are now available in places like Kineshie, which have not had the ability to do this kind of analysis until very recently. And they have also, again, because of advocacy, it's become much more affordable. So you have all of these crazy improvements in how we can address TB. So I was pretty excited about this. I went to a place, Ghana's a high-burden TB country. It's also a country that's really trying to make some efforts around primary care. And so I went there to Kineshie to see how this was working in real life. And one of the big problems with TB is that more than half of people with active infection don't know that they have the disease. They don't get diagnosed, and if they don't get diagnosed, they don't get treated. And so when I arrived at Kineshie, I learned about this excellent policy they have, which is that if you come in the door of this outpatient center, if you're a kid with malaria, if you're a woman in labor, you're an older person looking to get your hypertension treated, you get screened for tuberculosis. Somebody asks you a couple of questions about cough, and if your cough questions raise some flags, then you get asked about some other symptoms. And if those suggest that you're a possible case of tuberculosis, they take a sample and they send it down the hallway to the lab where they now have this, technology thanks to COVID. And so you go off and you get the rest of your care, you deliver your baby or whatever else you're there to do. But meanwhile, you're getting screened for TB. So they're gonna, and I think this is amazing. What a great policy. This is a national policy in Ghana. This is gonna pick up so many more people and connect them with this new and improved care, right? Except that in all the time that I spent at Kineshi, I didn't see anybody get screened for cough. Nobody had a sample taken. I saw the files of people who had tested positive for tuberculosis, but who hadn't been notified or started on the drugs. And when I talked to a few people who came in to pick up their drugs that day, I learned that nobody in their families had been screened, none of their close contacts. And this was the reason why. So this gentleman in green, writing in the files, that's the nurse in the clinic. His name is Richard Bodie. And the day that I was there, Richard was doing 4 people's jobs. He was covering for a maternity leave and a sick leave and another position that was sort of temporarily unfilled. So he wasn't at the clinic entrance doing the screening. He wasn't out doing the contact tracing in the community. He wasn't able to chase down samples from people. He was swamped just with doing basic checkups and giving out medication. So at the end of the hallway, here's this lab with this new PCR capacity and this ability to do diagnosis, and they're not diagnosing anybody. And people are consequently not getting connected with treatment. And international donors supply most of the TB drugs that are used in Ghana through the global funds to fight AIDS, TB, and malaria. They don't support operational costs in a clinic like this. And as you know, the reason things were not working essentially is that this clinic, first of all, has not been adequately staffed, which is the responsibility of the government of Ghana. But also, Richard told me, Dr. Yaodusi, who's the head of the national TB program, also said to me, you know, it's also that clearly you can see by the way this is breaking down in very basic ways, government has not prioritized, there is not political will about responding to TB. And that is because TB is perceived here like in Ghana, here in Canada, everywhere, as a disease of the most marginalized people, right? And so it just doesn't get that same commitment, it doesn't get those resources. And so that's what I wanted to talk to you about today, because I hear all the time, and you will hear through the rest of this event, about the promise of technology to resolve the glaring inequalities in healthcare access around the world. And as I'm sure you will hear, this is a moment of enormous possibility, right? So mobile data, artificial intelligence, the application of genomics, these are things that promise us the kind of huge leap forward in the quality of healthcare that we saw with like germ theory and vaccination and penicillin, right? You have these like moments where you have these openings of possibility. But the thing that I see in my work is that for any of these things to work, for them to make a difference, you have to do something else. And it's not something that's new or exciting or glamorous, and it does not attract rounds of venture capital funding in Silicon Valley. And that's primary care, right? It's primary care that is of high quality, that is culturally appropriate, that is accessible, without the hard work of building systems that are robust and are equitable. Then there's a really limited amount of impact that that innovation can have. And I want to tell you how I've come to think that. I get like probably 30 press releases every single day in my inbox. And I can tell you, after covering this for 30 years from more than 80 countries, I'm really deeply skeptical about how many of them are actually going to make a difference in terms of health for all if we're not willing to do the other stuff. So I was in Kenya this time a year ago, and one of the things that I was there to take a look at, I was reporting on non-communicable disease and how the rise of hypertension, diabetes, cancers has really snuck up on us, especially in a sub-Saharan African context, and we've made these incredible gains, 10 years of life expectancy, has been added to sub-Saharan Africa because of the success against infectious disease, HIV and malaria primarily. And while we were all looking over here, this other thing was happening that really threatens all of those gains. And so that's what I was there to report on, and part of that was looking at cancers. And there's a new cancer center at one of the main hospitals in Nairobi that I went to see, and it has some pretty advanced diagnostic and therapeutic technology. But in Kenya, so if we take breast cancer as an example, in Kenya, 60% of women who are diagnosed with breast cancer already have stage 3 or stage 4 disease, which obviously has a significant impact on how successful treatment's going to be. And that, by the way, is regionally a pretty good statistic. That number is 98% in Nigeria. 98% of women diagnosed with breast cancer in Nigeria are in stage 3 or stage 4 disease. So at present, the only cancer screening that takes place at all on a systemic level in Kenya is for cervical cancer. And that happens at primary care centers, but it happens at fewer than a third of primary care centers across the country. So for all other cancers, people don't get screened and they don't get diagnosed. And so the level of sophistication of the treatment that might be available to them becomes somewhat irrelevant, right? In Nairobi, I met Joyce Wawira Mtetu, who I spent some time with. Joyce was first diagnosed with breast cancer in 2014, and she already had stage 3 cancer at that point. She had a giant tumor, and she told me that she'd been aware of the tumor growing and been really worried about it, but she couldn't imagine what it was because she's not a smoker, and she was under the understanding that only smokers get cancer. There wasn't anywhere that she could go to get information about what this might be. She didn't know anything about breast cancer, and she was, she admitted to me, frankly, like a bit afraid to Google. She tried to see a doctor. Ironically, the only really functioning health facility in her community, which is a slum on the edge of Nairobi, is an HIV clinic, which is free and well-staffed and works really well. When she tried to go to an outpatient center to see a doctor in a hospital downtown, there were these huge lines. She'd have to spend a lot of money on transport. She'd wait and wait. She still wouldn't see anybody. She'd have to leave because she was trying not to lose her job. And so by the time she was diagnosed, she was really sick. And her, both oncologists that I spoke to and cancer support organizations in Kenya told me the only thing that's unusual about Joyce was that she was still alive to tell me this story when I met her. The same day that I met Joyce, I met the Deputy Health Minister of Kenya, and he told me that they're aware that this is a problem. They do have a national cancer strategy, which includes a plan to extend cancer screening to primary healthcare centers all over the country. And the hope is that they may be able to try to catch cancer like Joyce's a little bit sooner. So another really important part of a cancer strategy, obviously, is prevention. You stop people from getting sick in the first place. And a couple months after this trip where I met Joyce in Kenya, I was in Tanzania to report on a prevention strategy. So Tanzania has been a pilot for the rollout of the vaccine against the human papillomavirus. And that vaccine, of course, offers near total protection against this infection, against a sexually transmitted infection. That causes cervical cancer. And it's been given to adolescents in Canada for more than 20 years, but it's only now starting to be widely introduced in lower income countries. And that, of course, matters because 90% of the cervical cancer deaths in the world take place in low income countries. And so for all the reasons that we were just talking about with Joyce's situation, there's a desperate need for a vaccine like this in Tanzania, which also, like Kenya, has really limited cancer screening. So this vaccine this is an innovation that offers huge promise, right? It's, in essence, the only vaccine that we have against a cancer. Tanzania got support from Gavi, the Vaccine Alliance, which supports vaccination in low-income countries, to introduce this vaccine, and they did a lot of work to figure out how to do that rollout. They knew that they really needed to create demand for the vaccine. It's going to girls aged 9 to 14. That's not a cohort of people that normally would be having contact. They're not getting immunized. They're not normally having any contact at all, really, unless something goes catastrophically wrong with the health system in this context. So you're going to have to get to them and get them to have demand for this vaccine. So Tanzania worked with a number of partners, and they created chatbots and radio dramas and a very charming, actually, soap opera that I got temporarily a bit hooked on, and all kinds of these things to try to drum up demand in young girls. And then they rolled out the vaccine, and nobody wanted it. And they were really frustrated, right? You can understand why. If you were somebody running a health program in a low resource setting and you had something really effective and important to offer people for free, and people are not lining up to get it, you're going to be, you'd think people are going to be clamoring for it, right? And no, this is not what happened. So I spent time in Tanzania with these lovely young women at their school where there had just been a couple of efforts to try to vaccinate people. In a place called Upendo outside of Dar es Salaam. And after I got to know them at the school and to talk to their teachers, I went home with some of them and met their families, the priests at their church, or the mosques at the imams at their mosques. And I came to understand what had happened, why Tanzania hasn't had success in building out demand for, in getting demand for this vaccine. And the reason is, of course, that in Tanzania, 14-year-olds don't make the decisions about whether or not they get vaccinated. While they were busy making these soap operas that were selling the girls on this whole idea, they did nothing with parents. And in the context of this rollout, especially their sort of second big push at the rollout, came with COVID and all of the misinformation that had been circulating about COVID vaccines. But there was already, because this is associated with a sexually transmitted infection, there were already rumors that this was actually a vaccine about controlling girls' fertility, that this was coming from the West in some way to make young women sterile. There was a lot of concern about the idea that this might encourage girls to be more sexually active, which wasn't going to be culturally appropriate. All of which, frankly, are rumors that also have surrounded the HPV vaccine in North America. But what government in Tanzania eventually realized is that all of this messaging they had been doing had been targeting the wrong people, that there was no point creating this demand for this vaccine among teenage girls if what happened on vaccination day at the school was that parents all kept their girls home and said, you're not allowed to get this shot. It's kind of irrelevant what these girls wanted to do. And that's the kind of thing that I mean when I say that you need primary care that is also culturally appropriate and reaches people where they are. So let's talk for a minute about delivering that care. Tanzania's HPV vaccines and Kenya's new cancer screening are all going to be done by community health workers. And let me tell you, if I had $1 for every time someone has pitched me on some fantastic new public health intervention that's going to be delivered by community health workers. This is Misra Yusuf, who I met in June in Ethiopia. She's a community health worker in Harar. It's a city in the east of Ethiopia. Ethiopia, of course, has been heralded for its community health worker program. It was created in part by Dr. Tedros Adhanom, who heads the World Health Organization today. But back when he was Ethiopia's Minister of Health, he created this program. They call them health extension workers, and it was the bedrock of an effort to try to bring primary care to neglected communities across the country. And so Ethiopia has 40,000 health extension workers like Misra. And I met with Misra and I spent time with her and some of her colleagues while they were doing their jobs because I wanted to see what they do in a typical workday. I wanted them to tell me about their responsibilities. Let's see how many of them I can do. Misra does early childhood vaccination. So the area she covers has 13,000 people in it. She does early childhood vaccination and now also HPV vaccine for schoolgirls. She delivers contraceptives, so that includes pills, condoms, and long-acting contraceptive injections. She tracks infant nutrition. She provides antenatal care to pregnant women. She screens for tuberculosis and provides medication. She distributes bed nets and connects people who have suspected malaria with malaria testing. She screens older adults for dementia and tries to connect their families with support services. She screens teenagers for mental health problems and tries to connect them with counseling. did I get HIV? She connects people with HIV testing and distributes HIV medication. She screens for diabetes and hypertension, follows patients with those conditions regularly and gives them medication. She supervises improved water and sanitation services, which sometimes actually means that she takes the white coat off and she goes out and she digs a latrine. She's doing just this extraordinary number of things that she's responsible for. She's the only point of contact, right? For most of these 13,000 people, she's it in terms of their access to the healthcare system. It may not surprise you to learn she works far more than the 40 hours a week that she's paid for, and she's paid $90 a month. And she's one of more than 3 million community health workers globally. And the thing that's really shocking about Misra's salary is not the $90 a month, but it's in fact that she's paid at all. 86% of community health workers in sub-Saharan Africa are paid nothing, ever. They're just unsalaried. And they do a list of things as long as what Misra does. They're not properly compensated, they're not professionally trained, they're not supported, and while many of them work incredibly hard and are incredibly devoted to what they do the way Misra is, many of them, including Misra, are in this job in the hope that they can use it as a stepping stone out of the job. Misra hopes to qualify as a nurse, which, as you may have inferred from hearing about Richard's job in that clinic in Accra, is not always great either, also hugely overworked and exploited and quite badly paid, but Misra feels it would be a step up. But if you think about the two of them and that chain, it gives you a sense of why healthcare workers are applying in unprecedented numbers to emigrate, and also why they are being rapaciously recruited by healthcare systems like ours in Canada, where we are fast-tracking immigration processes for nurses from places like Ghana at an unprecedented rate. So, oh, the community health worker thing. While I was reporting on this story, I spoke to a number of senior staff members at big global health organizations. You know the ones that I mean. And they spoke to me off the record. Nobody was willing to talk to me about this on the record. But they told me about being in board meetings with the leaders of their organizations where they would be celebrating the fact that new innovations, new programs were things that could be delivered by community health workers. In other words, for free. There would be no line items for salaries because you don't have to pay these people, right? So you're talking about, in some cases, billion-dollar global health programs where it's premised on the idea that you will deliver it, last mile delivery will happen by someone that you don't have to pay. Of all of the big global health agencies, only the Global Fund to Fight AIDS, TB, and Malaria recently introduced payment of community healthcare workers who deliver these services as a key performance metric for countries that receive their funding. Other donor agencies don't require it. Aid agencies don't do it, often because salaries don't fit in a 3-year funding cycle the way that a particular program with a start date and an end date does, or the way that a big purchase like 100,000 bed nets fits in a budget. Ongoing salary support is typically not within their mandate. The big global finance institutions, the World Bank, the International Monetary Fund, they in fact often make it a condition of budgetary support to a country that there's a cap or a complete block on public sector salary spending. So that includes healthcare spending. If you're going to get this bailout that you need from the IMF, you are not allowed to spend money on healthcare salaries. And so I don't think it's a coincidence that countries themselves are not remunerating these workers or remunerating them fairly out of their own funds, because the overwhelming majority of them are women. And like Misra, they are women with limited education who live far away from capital cities, and the perception is that they don't deserve fair wages or professional support. Which brings me to the idea of equity. A couple of months before I went to Ethiopia, I was reporting on cystic fibrosis. And as many of you may know, there's been a real revolution in the treatment of cystic fibrosis in the last few years, thanks largely to drugs that are made by a US pharmaceutical company called Vertex Pharmaceuticals. They've made some very powerful drugs that have the sort of most headline drug out of all of them is called Trikafta. And these drugs have dramatically extended the life expectancy of people with cystic fibrosis and really changed it from being, a completely debilitating disease that with a very shortened life expectancy in around the world to, for people who have access to this drug, a very, very different thing. And Vertex sells an annual course of Trikafta for $520,000 per patient. And this is a drug that you would need to take every year every day for the rest of your life. So Vertex has registered that drug in every country around the world, even Vatican City, so that its patent is protected. I have spent decades reporting on drug access, and even by the standards of what I have seen in that reporting, this was one of the most remarkable examples I have ever encountered. Vertex has no compassionate use program for access to Trikafta. It has no tiered pricing. It has no license with the United Nations Medicines Patent Pool, which allows other companies to make a drug in exchange for a royalty that's paid back for the company. They don't do that. They have no license for generic drug makers in low-income countries. Again, no tiered pricing, so it's $520,000 a year. It means that people with cystic fibrosis outside of Europe, the United States, Canada, where the provinces, they won't disclose the number, but they have negotiated a slightly lower price for Trikafta, but nobody I spoke to thinks it's that much lower. Nobody else has access to the drug. It's essentially $520,000 or nothing. You can't import it, you can't get it, and you can't buy a generic. There is no generic. And because this is an increasingly connected world, people in other parts of the world know about Trikafta, and they know about this revolution that's happened in the lives of Canadians with cystic fibrosis. So this is a family I met. This is the Shri family. That's Vihan, who was 5 when that photo was taken, with his mom, Shveta. They're in Facebook groups with people with CF all around the world, and so as a consequence, they know what they're missing, right? They live in Hyderabad in southern India, and they're desperate to get this drug. They've been in a support group for CF families since Vihan was born, and one by one, they've watched all of the kids that Vihan became friends with in that group die. The family, their annual income is somewhere around $8,000, $9,000. They're not buying Trikafta. I mean, they can't buy Trikafta because nobody sells it in India, because you're not allowed to import it. You can't make it generically because the company's registered the drug. When the Shri family and other families from this support group meets with the government of India and begs them to figure out a way for them to get a more affordable version of this drug, the government replies that its hands are tied. Its hands are tied because of the trade-related aspects of intellectual property agreement. You probably know it as the TRIPS agreement of the World Trade Organization, to which India, of course, is a signatory. This is not just an Indian problem. In the past few days, I have been talking to people in the health ministries of Brazil and Colombia about HIV drugs. They're really struggling to provide HIV medication in their populations. Middle-income countries don't get the same access to cheap generic drugs that have made HIV treatment accessible in sub-Saharan Africa. So the best treatment on the market today for HIV is a drug called dolutegravir, a combination therapy. It's $45 a year per patient per year in most sub-Saharan African countries. It's many thousands of dollars in middle-income countries like Colombia and Brazil, both of which have a very large population of people living with HIV. Colombia recently took the very unusual step of issuing, the first time it's ever done this, a compulsory license for dolutegravir, because they're so frustrated with what the company is charging them. Because these drugs are too expensive for Brazil or Colombia to be able to buy them, people on HIV in those countries who rely on the public system are on an inferior treatment that doesn't suppress the virus as well, that has a higher side effect profile, that just is, it's an inferior treatment. As a consequence, they're not as drug adherent. their viral load counts their virus is not suppressed in their bodies. Both Colombia and Brazil have rising HIV infection rates for the first time in a decade. And the people I was speaking to in these ministries draw a direct line between the fact that they're using an inferior treatment because they can't afford dolutegravir. It stems, again, this problem, this HIV problem, directly from the functioning of the global patent enforcement system. So cystic fibrosis patients describe Trikafta to me as a miracle. A lot of people would say that about dolutegravir too. Vihan's mom, Shweta, when I talked to her, said to me, it's not a miracle if only a handful of people can get it. That's true for dolutegravir. It's true for Trikafta. It's also true for much less sophisticated innovations. When I think about Joyce in Nairobi with her breast cancer diagnosis, she eventually got she got surgery for the tumor. She needed chemotherapy. And even in the public system in Kenya, so using a public hospital, chemotherapy was $2,100 for breast cancer. Joyce was earning about $30 a month. So her church held fundraisers and they raised the money for her to get it. Sometimes she'd get a treatment. She's supposed to be having them every 2 weeks. It would be 3 months before she could get the next one. Kenya has a new national health insurance scheme that's supposed to help make access more equitable. $2,100 under that, the national health insurance scheme, that is not something that somebody like Joyce can afford. So building out drug and treatment systems is great, but not if they're systems that not everybody can access. It doesn't really matter to Joyce how much we've improved treatment for breast cancer if she doesn't get it, and it doesn't matter how amazing the new therapies for illnesses like CF are if Vihan can't get them, or vaccines against cancer if we haven't done delivery right and the girls in Upendo can't get them. If our technological innovation is happening in a context of systems that have inequality baked into them or that haven't been designed in ways to sustainably reach everybody, then they're not going to produce health for all. So I'd like to tell you one more story. 2 years ago this week, I was in Zambia reporting on the COVID response and on vaccination. And of course, at that point, we here in Canada, most of us were multiply vaccinated, but COVID vaccination coverage in Zambia at that time was about 7% of the population. And I went to a rural hospital in a place called Chongwei to look at what was happening. They were trying to build some uptake for the COVID shots when they could get them. And I found myself in this room. And I walked in there, and I just stood there in shock, like sort of literally slack-jawed for a little while. And the reason was that I realized that I had been there before. And the last time that I went to Chongwei, to the Chongwei District Hospital, was 17 years ago. And it didn't look like this. 17 years ago was the height of the HIV epidemic in Zambia. About 34% of adults were living with HIV at that time. HIV then was a treatable illness, was largely a chronic illness in Canada, right? People with HIV in Canada were being connected with care. But when I went to Chongwei, the last time I was in this room, there were 3 patients in every bed. There were patients on the floor between the beds. There were patients in the hallways. There were patients out in the long, open-roofed corridors that connect the buildings. There were patients on the lawn. We don't see this so much anymore, but if you have seen it, and I'm sure there are some of you in this room who have, you never forget it, what it looks like for a person to die from late-stage AIDS, right? They're skeletally thin. Their eyes are sunk back in their heads. They're gasping for breath. It's horrifying. And this room and every room in the hospital was full of people who were dying of HIV. And I stood there in this empty room, and I said to the medical officer who was giving me a tour, I said, where is everybody? And he looked at me like I was a little bit crazy. And I said, I haven't been here for 15 years. And then he was a young guy who probably has never worked in the system when it looked like that, but he thought about it for a second and he got it. And he said to me, like really casually, he said, oh, well, we have 40,000 people in this district on antiretroviral therapy, by which he meant they are out living their lives the way you would be if you had HIV in Canada. And to look around this room and see the curtains folded up out of the way because nobody needed the beds, it was really one of the most remarkable moments in my reporting career. It looks like a very boring room, and I have to tell you, if you'd seen what I saw in that room 17 years ago, it was just the most extraordinary sight. So what got us there? What changed things in Chongwei? Was obviously innovation, right? It was biomedical research that led to discovery of antiretroviral therapy to control HIV. And it was innovation in drug delivery. It was improvements in taking those therapies and turning them into one pill that could be taken in a single pill today, and a therapy that could be delivered in a place like this with really limited health infrastructure. It was the development of things like point-of-care viral load testing so that you could track patients in really low-resource settings. Huge story of innovation, the response to HIV. It's not a TB success story alone, it's not a technology success story alone, right? It was also the relentless work of activists like my friend Zaki Ashmet, who's in this photo with President Mandela. Zaki founded the Treatment Action Campaign in South Africa, along with a lot of other people who were living with HIV. And the Treatment Action Campaign, in an absolutely exhausting and incredibly, I was fortunate enough to live there in South Africa at the time and to watch this happen. Zaki at that moment was on a drug strike, and he was pretty close to death, actually, when Mandela came to see him in Khayelitsha, outside of Cape Town. He was on a drug strike against the government of South Africa and also against pharmaceutical companies demanding access to affordable treatment. Treatment at that point was $20,000 per patient per year in Canada, and obviously completely out of reach for South Africans. The Treatment Action Campaign forced companies to bring the prices down, generic treatment down to $120. They forced world leaders to come together with a global plan for HIV response. They built drug distribution and adherence and testing and counseling services when they had really been all but abandoned by the health systems in their own country, although in fairness, the health systems in places like Zambia were absolutely buckling under the pressure of the HIV epidemic. Yes, the research, the innovation was so important, but also this is who saved the lives and helped to empty the Chongwei Hospital and all of the others. You know, eventually, after a devastating loss of life, there was huge investment in HIV care, and it led directly in many countries to the expansion of what had been a very rudimentary primary care system. It led directly to the extension of services to rural areas like Chongwei. It led to the recruitment of community healthcare workers, to efforts to reach the most marginalized people and connect them with care. That was also innovation that saved lives as much as drugs and testing did. So I'm really excited about a lot of the new technologies that I've seen recently. I saw recently handheld ultrasound machines that community birth attendants can use to give women ultrasound scans in really low resource settings, and then they can upload those scans on their phones and send them to the capital city where someone can a specialist can diagnose something like placenta previa that might require a surgical delivery, which will give you time, hopefully, to get a woman to a place, although if that place is 7 hours by motorbike from where she lives, there's still a problem, but it gives you a window of time to try to connect that woman with care. There's a project in Lesotho that's using artificial intelligence. They're doing rural x-rays, portable x-rays on people with lung conditions, and in the context of Lesotho, incredibly high TB prevalence, high HIV prevalence, but also a huge number of men from the country have gone to work in the mines in South Africa, and they come back with mining-related lung disease, and you're trying to figure out what people have and whether they should be on TB diagnosis. So there's 2 radiologists working in the capital who were responsible for all of the x-rays, and so now they're sorting them with artificial intelligence, which in the research is showing It's as good as a radiologist at identifying the ones that should get a closer examination for tuberculosis. And so that's helping to connect people with care much faster. I hear about a lot of developments like those, a lot of technologies like those. The people pitch them to me always as things that will help low-income countries compensate for the gaps in education and training, for the human resources that they lack. But, you know, ultimately, the people that we diagnose in all of these situations, they're going to need care. They're going to need care that's going to come from another human. It's going to have to be accessible and affordable and delivered by people who are remunerated and trained and supported and whose work is valued. And I really don't think, after 30 years of looking at this, that there is a piece of technology that is going to take the place of that. Thank you very much for listening. I'd be very happy to answer questions if you have any.
Thanks so much, Stephanie. That was really, really thought-provoking. We have a couple of runners, Caitlin and Linda, to take your questions. But as you're preparing your questions, I'll take MC prerogative and start with a question. So the title of today is Health and Wellbeing for All by 2030, which is SDG 3, right? I'm a global health researcher. I study SDG 6, water and sanitation, and particularly how that impacts women and girls. I know many of these healthcare facilities that I've visited have no water. They're trying to do surgeries with no water. You're trying to do deliveries of babies with no water, no sanitation. And as a researcher, I have this tagline that people know me by, which is 3 through 6 by a 5. That is, if we want health and well-being for all, we have to have water and sanitation for all, but we're not going to have either of those things until we empower women. What are your thoughts about that?
Yeah, I mean, the water one, oh, I keep going places where people like show off some new, like they show off their Gene Expert machine, and I'm like super glad they have the Gene Expert machine, but also there is no running water in the primary health center, and I just think like, we're going to need to do both of these things. I mean, the water and sanitation, I think in particular in South Asia, the years that I was covering India, was so important, right? Like, it so directly correlates to many health challenges that women face, but like again, like thinking about a program that hasn't necessarily been designed to take culture into account. It's like this huge effort to build community toilets in India, and then you have this really strong inbuilt gender barrier to women to going to use them, and so they don't get used by women, and they haven't solved the problem, and then you haven't solved the open defecation problem, and you haven't solved the impact that has on the health of children. I love the goals. I think the goals are important. I've spoken to enough people who work in like individual programs. You know, there's a bunch of countries right now that are celebrating elimination of lymphatic filariasis, and I'm writing right now about hepatitis and Egypt's huge success with hepatitis C. The goals, for whatever reason, help, right? Like, they give people a target. I also, I don't know how we're talking about health for all by 2030, if that's also theoretically when we're going to have water and sanitation for all. Like, I just feel like we might need to do one of those things before we get to the other thing. I don't know.
Good. Questions from the audience. Caitlin, there's one right. Oh, sorry. You know what? These lights are really bright. I don't know if we can do anything about that, but I see Tom there. Yeah.
Well, thanks so much for such a wonderful talk. I have a question for you. You mentioned...
Like, I can't see you.
Yeah.
No, I found you. Okay. Yeah.
Yeah, you mentioned pharmaceutical companies, and you probably know that at least in Africa, there is this perception of big pharma plot or conspiracy by which there is understanding that these big pharmaceutical companies make sure that there's no possible alternative medicine that's put in place to support local populations. Yet, at least in 3 or 4 countries, with COVID, for example, some government allowed some local expertise to come up with local production that were actually very, very effective in treating COVID. That's also the case for other things. And you also remember the controversy that was happening during COVID, especially with Professor Raoult in France, whom Macron visited and for some reason was shut down. So, I mean, in your travel throughout the continent, what space, if any, did you know was put in place to support local expertise and infrastructure? And how effective has this been? Thank you.
Yeah, it's a great question. It's really hard, right? It's when you talk about a big pharma plot to keep drugs out of countries, I'm a I'll raise my hand as a person who subscribes to that conspiracy theory because I literally report on it. I'm working this week on a story about the new gene therapy for sickle cell disease. And where is the world's biggest burden of sickle cell disease? It's in Nigeria. This therapy is going to cost $3 million per patient. Are Nigerians going to get that drug? I have questions. Or get that treatment, that therapy. Many things seem to me to be fundamentally broken in the way that the pharmaceutical industry operates. And, you know, the company will tell me, I could tell you line by line what they're going to say. They're going to talk about the critical importance of research and development and how if they can't charge these prices for drugs, and they will gloss conveniently over the fact that about 75% of the research for this gene therapy was done using taxpayer money at academic institutions like this one, right? I think that system is very broken. The question about alternative therapies, I think is interesting because I think it's difficult to do, right? If you're to raise the money. I was just in Colombia. They have a number of alternative therapies for leishmaniasis that are, in their very small studies, they've been able to do really promising. It's a drug that's coming from the global south, so it's facing this enormous, or a series of treatments that are coming from the global south. They face these huge barriers. They figure they need $3 million to do a big enough randomized controlled trial that they might actually get the results that would allow them to take this drug internationally. This little research institution in Colombia doesn't have $3 million. One of the therapies they're doing is something that's been used historically by indigenous communities in the Colombian Amazon to respond to leishmaniasis, and they don't have the $3 million that might help them get the trial results that might make their treatment available to more people, right? And so the system is very structured against making space for a treatment like that. I think it will be interesting to see what happens with this, you know, one of the grim lessons of COVID in terms of vaccine access was that you need capacity. You cannot have all of the capacity to produce therapeutics or vaccines be in countries in the global north, because then there's just no access for the rest of the world, right? And we certainly saw that with COVID vaccines. So there's this big push to develop mRNA vaccine manufacturing in different parts of the global south. I think that will be interesting if it works. I think there's maybe more hype around that than is entirely justified. But I do think quietly, sort of away from that spotlight, there has been new investment in pharmaceutical capacity certainly Indonesia has seen a big expansion, Egypt, Thailand, Colombia also actually to a degree. And so I think it is possible that those are going to start to be stronger industries, and there's going to be more South-South partnership in terms of development and markets. And so I think that is the only thing that I see currently on the horizon that might start just to address some of that problem you're describing.
Thank you for a wonderful talk. Is there a way to push back against these big pharma companies when they claim that it costs hundreds of millions of dollars to take a drug from an idea all the way to the market? And also the fact that generic drugs sometimes have quality control issues, and how can we address that to make drugs more affordable?
Yeah, I mean, they're not, it's unfortunate, especially this year, there's been some very horrifying news stories about quality control for Indian generics that have had tragic consequences, the lack of regulation that, I think, is going to depend on the Indian government getting serious about it and actually doing quality control and doing the oversight that they claim that they're providing for that industry in India now, which they, there's a ton of reporting by my colleagues that shows that demonstrably it's just not true. That may start to make space for others like these Thai and Indonesian companies I was talking about to get into that market. The only way that the only sort of route that I say that's available to me is to just keep making the point in these stories. We will make the point in this story about the sickle cell therapy that the company did not start with an idea and take this drug all the way through. They took a technology, the technology that won the Nobel in 2020, God, I've lost all track of time. It's a CRISPR-based therapy, right? And its application to sickle cell, again, grows out of American research institutions. They took it the last part of the way. For them to claim that they came up with this out of whole cloth is just demonstrably false. And it's hard, they have a great big marketing budget, and it's hard to push back against that narrative. I would like to see just consumers start to be more aware, and I think maybe COVID vaccines helped with this a little bit, to think about how, it's the story of almost all drugs and vaccines, right? Is they originate in academic research and in publicly funded institutions, and I try wherever I can to make the general public aware of that. I find it, so as a Canadian, just put my Canadian hat on for a second, it's very interesting for me working for an American publication with all American colleagues who write about the American healthcare system. So we have staff meetings sometimes where I'm like, are you people all crazy? Are you nuts? This is not, when they talk about, somebody said to me one day in just complete bewilderment, well, what does insulin cost in Canada? And when I told them, and they were like, well, what, you got some weird bargain basement insulin in Canada? Why is your insulin so cheap? And it was no, you live in a crazy, crazy world. It's just the rest of us out here. So this gene therapy that's going to be $3 million is assessed as being cost effective in an American system because the cost of treating someone with sickle cell is more than that. I think the fact that so many of these innovations are coming out of the United States with that kind of pricing is really complicating this whole conversation, because those are not prices that are economically rational, even in other industrialized countries. I would like there to be a much bigger public conversation about drugs and where they come from and what they need to cost in order to continue to make research viable. It is better if you don't end up with something like the treatment action campaign's years-long drug strike in which people literally died to try to bring down the price of those drugs.
So I think we have time for John's question, and then one more question, Caitlin, you have after that? Two?
Hi, I'm John Hurdes at the School of Public Health Sciences.
Oh, there you are. Hi.
So you can see me, okay.
Yes.
In your talk, you kind of approached but didn't quite get there on a topic I'm interested to hear more from you about. As we see a reduction in infant mortality, reduction in infectious disease rates, and longer survival, the next big challenge for Africa is going to be population aging. And so I'm co-leading a 12-country research initiative for primary care for older adults in African nations, and it's got a lot of potential to it. But getting folks to pay attention, decision makers to pay attention to aging in Africa is pretty tough. So I wonder if you want to comment on how to get there to raise better awareness and a better response to population aging.
Yeah, that's. I'd love to hear more about that project because that's so interesting. I've written about it a little bit, and it's hard, as you will probably know, it's hard to peel yourself out of the infectious disease vortex, right? But I actually think that that's that's a big part of it, right? Like it was so interesting talking to both the Kenyans and the Tanzanians about this because they're really aware, really aware of the problem. And as I'm sure you know, there's great research being done by public health researchers in Kenya and Tanzania and Uganda about this question. They know, like they see the numbers and they have some sense of the imminent disaster, the extraordinary rates of hypertension, like when you screen, which doesn't happen, the extraordinary rates of hypertension and diabetes in particular that you find. So much of like the skewing of the health system and where the response goes that's so built on the architecture of the big agencies and the donor money and like the influence of the Global Fund and PEPFAR and the President's Malaria Initiative and just the Bill and Melinda Gates Foundation and the list of things that the Gates Foundation cares about, right? You know, frankly, I've been in countries where the Gates Foundation is essentially a parallel state, right? You cannot overstate their importance in terms of the funding they throw around, but also any of you who do research in this field will know it's also really hard to get research money for something that isn't a Gates Foundation priority, right? Like it's just this, it's this kind of, and like God love them, right? Like one of the reasons we have a malaria vaccine is like nobody else, when Bill Gates threw all his money into malaria vaccine research 25 years ago, nobody else was like wandering around saying, I think I'll commit hundreds of millions of dollars to a malaria vaccine. Like fantastic, but it really shapes the whole conversation. It shapes with, you know, in the donor community, but also within countries and within ministries. And, you know, Joyce's example, she could get great malaria or HIV care free in a beautiful clinic with beautiful running water. Susan, like just, oh my God, I go into these villages and there's like this tumble down, broken windowed, broken roofed little primary care center where they're weighing the babies and vaccinating and doing like assisting with emergency deliveries. And beside it is this gleaming pop-up Quonset hut with running water and a little like air-conditioned room for the server that says gift of the people of the United States. And it's the HIV, TB, malaria. It's the PEPFAR building. Great, like fantastic, like that PEPFAR is one of the reasons that the Changwei Hospital doesn't look the way it does anymore, but you know, meanwhile, there's like 50 people with hypertension. Like, it's like we care about people to keep them alive long enough to like get through early childhood, and then we care about women again, like briefly when they're delivering babies, and then we just wash our hands of them, right? Like there's no equivalent large-scale intervention for older adults, as you will know better than I, and it's really, I think, really hard to, even for countries that are aware that they have the problem, it's hard to turn that ship when so much of the ship is fueled by the existing global health system and its focus on infectious disease. And it's like, it is like a giant cataclysmic looming problem that everybody can see it. It's like the climate change version of global health, right? Like it's like everybody can see it and it's coming and it's disastrous, and the amount of resources and energy and attention that are focused on it are not at all commensurate with the size of the problem.
Okay, last two questions.
Mario Pinto, University of Manitoba. First, let me congratulate you on your passion and your tenacity. Remarkable. Your comment on the reluctance of individuals to get involved in certain drug regimes and so on triggers a comment and a thought from me. You know, we've been involved in India with a major project on maternal child health, funded through the Gates Foundation, but then subsequently by the state and national governments, in this case, the state government of Uttar Pradesh, and then the national government. And that is our model to begin with the Gates Foundation, for example, and then to have the country governments take over. It's a program at scale, 380,000 frontline workers, serious stuff. But the comment I want to make is the following. We found it very convenient and essential to have a connector so that people participate in these programs on maternal child health. Okay? So we've set up community centers, as you've shown. Uttar Pradesh is 70% rural, so this is non-trivial. But the way we get mothers to bring their children in for inoculation and so on is to provide these connections, and the connections are the following. advice on family planning, birth control, on nutrition. This is a huge problem because of the diet and iron deficiencies in women in India. Right? But on top of that, we teach them to read. And that is the connector. The connector is empowerment of women. And that relationship then leads to a willingness to participate in other drug programs. So if that helps, I mean, we found that to be a pragmatic way of going forward. If I may just comment on the drug development issue, since that is my field. One of the biggest issues and why the factories was shut down in some of the African countries was one of quality control. Okay? And it's not just restricted to the global south or the developing world. So during development of the AstraZeneca vaccine by Emergent, and also the J&J, Johnson & Johnson vaccine by Emergent, that was a colossal failure because of quality control at scale in filling those vials. So I think one cannot ignore that fact, right? Reducing costs is another issue completely where one has to subsidize the cost. And several pharmaceutical companies are on that path. But the main issue is QC, quality control. And you mentioned this.
Yeah.
So I'd appreciate your comments, but just freewheeling here. So.
You know, I'm really glad that you mentioned Emergent because that always, I mean, I just did it. We all talk about, the quality control issues that have been in the news this year from Indian factories, but Emergent, and I think that what happened at that Emergent factory that massively delayed the rollout of the Johnson & Johnson vaccine that so many sub-Saharan African countries had contracted for, that had a direct impact on levels of vaccination coverage. It took so long for the vaccines to arrive that, you know, people's enthusiasm for being vaccinated had waned dramatically. Your connector point is also a good one, and I've seen lots of variations on those programs. One of the things they're trying now in Tanzania with the HPV vaccine is that they're pairing it with optometry checks, so like eye checks and some nutrition monitoring, and just trying to put together a kind of fun package of other health interventions that they can offer girls at the same time as the HPV vaccine, which I also thought was interesting because it was like, I don't know, it was like the kind of cake sprinkle approach to healthcare, right? Like it's like, come on in and you can have your 15 minutes of healthcare that you're gonna get before we send you away again and don't engage with you unless you have a child, and then you leave again, and then regardless of what your heart disease status may be in 25 years, we're not interested. But it was, you know, it is proving, it seems to be, they don't have, I don't think they have final data on this yet, but it does seem to actually be serving to bring people into the clinic. And I think, like, you know, if you can, yeah, sometimes I think that's what it serves two functions, right? And I'm sure you found this in Uttar Pradesh as well. It can serve the function of obviously connecting people with more care, but also sometimes putting a bit of a distractor into the conversation about what you might be doing there, which can also help in terms of making something more culturally accessible.
Caitlin, do we have one more question or, oh, one more. Thank you. Last question.
Goigoi, Sego, Ani Boju. Hello, my name is Benny. I work here at the University of Waterloo. I'm a Mi'kmaq Kapampangan person, and I have a question. But before I ask it, I want to contextualize my question by handing the mic over to Elder Maingren Henry again, who also he's a traditional medicine knowledge keeper and a traditional healer. So I want to give him a chance to just say a few words.
Bujo, you know, in the 70s, First Nation communities were denied a lot of medical attention throughout Canada and the United States. And it wasn't that we weren't able to access medicine, but the traditional knowledge keepers and medicine people were able to continue on with the way that we practice medicine. And so I was able to actually build a huge ability to, you know, tackle some of our health issues through traditional medicine and knowledge. But I think part of that knowledge needs to also interact with our spiritualness that we have. And I think for Indigenous health in Canada, we're seeing results now because we are incorporating both aspects of healing together. And I think, I really believe in science, and I believe that it's strong, but it only meets our health issues halfway if we don't deal with the side that we understand to be our spiritual side. And so growing up, knowing that, I think I've seen many of our people on First Nation communities, die rather young because of healthcare coverage in Canada not being as adequate, especially in the north. But I really hope that, with this conversation, we have a chance to look at all aspects. I do work with medical students at McMaster, and they're very interested in learning more about Indigenous health practices. So I'll leave the question with Ben now, but I just wanted to bring that to your attention. Miigwech.
Thank you, Mangan. So I just wanted to let Mangan share a little bit, because I really appreciate that you mentioned right at the beginning of your talk that you're reporting on systems, and in recognition of a lot of where, the systems that we are, we're talking about certain health, systems in a larger global system that's underpinned by colonial history, right? And I mean, just like Mangan, I know that a lot of my relations in Africa have a wealth of Indigenous knowledges and practices that can be really, really helpful in this conversation. And I was just wondering if you've noticed on your travels and on your reporting if Indigenous knowledges and ways of knowing and being and that recognition, if you're starting to see that being re-implemented into the healthcare systems in these countries. And if not, do you think that they could possibly benefit from that more holistic view? Because not only is that going to include our spirit, but I think it'll also include a lot of these systems, these flawed systems that we're looking at and that we're witnessing.
Thanks, Benny. Thanks for that question, which is super interesting. I would say what I see over and over again is that it hasn't been lost, right? So traditional knowledge, and it remains very, people remain very connected to it, right? So I was just reading something yesterday about how in Uganda, 72, 73, some extremely large percentage of people say they routinely consult a traditional healer first before they go to the Western medicine system still. And this was in the context of looking at, okay, how are we going to work with these people? The thing that I don't see is I don't see that integration that you're talking about. And I would say very often I see projects that are aimed at minimizing or containing or hiving off the role of traditional healers. I do see some where there's a recognition of how important they are to people and the role they play and a conversation about partnership, but very often it's a binary, right? It's I go here first and I get help here, and then maybe I'll also go to this clinic, or I'll go here and if it doesn't work, maybe I'll go there. And quite often, those systems end up being in quite an adversarial relationship, which I can definitely understand. There's been so many examples, right? But the laying on of hands to cure you of HIV, or all of the people in the early years of HIV in sub-Saharan Africa, in South Africa, who made money on completely, they're just exploiting the desperation of people who couldn't get access to other treatments by nakedly selling things that were, I think there were people making genuine efforts, but there was also just a huge amount of crass exploitation of people's desperation, which then I think makes the kind of more Western health system have a sort of adversarial relationship, right? So the thing that I don't really see happening, but which I think would be so good on so many different levels, the ones that you mentioned, but also getting people connected with care maybe more effectively and in a way that felt like a place where they were more heard or more comfortable or understood better. There'd be so many benefits from trying to integrate those things. And that is not a thing that I've seen very many places very often. I guess it's 1970 in most of the places that I report. in a number of ways, regrettably, like also in terms of access to therapies and lots of other things.
Thanks so much, Stephanie, and thank you for your great questions that have really started a tremendous dialogue to set the foundation for the rest of the day. I'm sure you'd like to join me in thanking Stephanie for her provocative comments.
So that concludes the presentation part now, and this is now the audience participation opportunity. So if any of you have some questions that you'd like to, we have one already. Excellent.
Can you hear me?
Yes.
Wonderful. Thank you so much, Michelle. I mean, I love the presentation. I was just curious, when you talk about robotics, what are prospects about affordability and their applicability in countries where, as you mentioned, resources are scarce? I mean, you mentioned Botswana, which you will probably appreciate is not the least privileged country on the continent.
That's true.
So I know of other spaces where rehabilitation is, I mean, if not a luxury, but it's close to non-existence.
Yeah.
So how do you navigate all this, and how do you make it, well, inclusive, A, in the US, and B, beyond that, including the specific case of Botswana, which, as you know, it's a relatively wealthy country? Thank you.
No, thank you for that question. You're right in that Botswana would be considered a middle-income country, and that's one reason why in Botswana we are working in their urban space as well as their rural space in a primary care hospital that's in their Mahalape district. So we're trying to kind of like create this experience that you're talking about. One of our key things to making the robotic system a little bit more affordable is we ported to Botswana the pieces that we could not get there locally. And everything else, we depended on our engineers at the University of Botswana to develop the rest of the system. So I think that was one way to kind of drive costs down compared to what it takes to manufacture this system. In the United States, it was at least almost like a fifth of the cost to do it in Botswana on country, and also building rehabilitation capacity, because we worked with the clinicians, we worked with patients, we worked with engineers to be able to develop a more affordable system there. You're right in that some of the rural spaces, we found that transportation was a huge issue, just even being able to get to the robot or get to the hospital where we placed the robot system. So in fact, going forward, we've been thinking about how do we develop an implementation type research where we really consider putting the robot in, in the closer to where these villages are, where people have lack of access, and then making it maybe a community center or in a primary care facility that's closer to the village. Or another thought we've been looking at is mobile, like a kind of a mobile truck where the robots are on the truck and we kind of drive someplace. So we're looking at ways to deal with the discrepancy in care that happens in Botswana, even in the United States, but also would be amplified in other places. Hopefully that answers.
Very good. Oh, there. I think a microphone's coming. Very good. Oh, okay.
I have a question for Dr. Savage. When I was young, almost everybody smoked, but then there was this great education campaign, and now smoking is reduced greatly. Why can't we do that with opioids? What will it take to get the young people to not go there, just not get into that to cure that problem?
Yeah, thanks for that question. So I want to preface that with I'm not an addiction specialist. Unfortunately, I deal with the consequences of the overdoses and not the upstream sort of challenges. But I think a lot of it has to do with, like why do people develop addictions, right? It has to do with like lack of, education, lack of social supports, lack of, things like housing and family and supports and all sorts of things. I think, as I said earlier, I think it's not just one simple solution to any of these issues. There's all sorts of, system level things that we can do, but there's no quick fix, right? Like this is going to take a generation. And unfortunately, the opioid challenges that we face was physician-driven, unfortunately, right? Yeah. Physicians had advice from pharmaceutical companies that these medications were safe, that you're going to help your patients, and they followed that advice for a long period of time, and many, many people have suffered as a result of it. So.
In the back.
Thank you for those presentations. My question is regarding the robots in Botswana. So do you anticipate any legal or regulatory issues? And what might those look like? Because I don't imagine that there are none that you will encounter in trying to set up that form of care in Botswana.
Yeah, thank you for that question. Because we're doing research at this point, the regulatory experiences that we've encountered are more to do with the IRB and making sure that we have permission to place the robots in this hospital and to work with the patients with HIV and stroke, or a combination of the two. When we're, in fact, the startup company that that I'm a part of is trying to work through, well, how do you then take it to the commercial level? And in Botswana, for example, our colleague there at the University of Botswana have identified, for example, the Motor Vehicle Association there is a primary source of funding for people that have had motor vehicle accidents that have ended up with spinal cord injury. So we have been exploring how do we literally partner with these government agencies and the Ministry of Health to make this something that is viable. And so that's kind of in the works, because you're right. Right now we're there in a research space, but if we can prove the utility, and right now the research is being funded by the National Institutes of Health, the Fogarty International Center, but what we hope is that by demonstrating the usefulness of this technology, we could build one capacity. We could also build collaborations with the Minister of Health, the large entities, private and public, I would think, and NGOs, to say, how do we make this kind of, deployed and deployable? One of the biggest things that we found in Botswana is there is no infrastructure for building or creating rehabilitation technology, even basic assistive technology within the country. So a part of it is working with engineers. I mean, that's one of our strategies, is to build through the schools, because if we can work with professors to create a rehabilitation mindset and an engineering mindset, we can actually make a change on the ground, where we now have engineers who say, I can do that and I can maybe innovate within that space. That's one of the things we have to do.
Thank you so much for your presentations. I have one question for you, Michelle, and one for you, Dave. You mentioned in your presentation that your younger participants were more inclined to using the robots, and I was wondering if, with the turn of COVID-19 and young people interacting more and more with technology and less with human contact, if there was an even increased enthusiasm for using robots. Because we're seeing more and more young people having anxiety interacting with fellow human beings. So I think that's quite interesting. And then for Dave, I'm wondering if you have heard of any community-led initiatives to address this issue around inequitable access to reaching ER services or departments, and maybe in your work how hospitals can really bring in the community to address this issue, and not maybe overly depend on our government systems to address some of these challenges. Thank you very much.
I'll go first, but I'm actually going to pivot to Kirsten, because she works more with the young kids in your social robot. So I will just say, in our brief experience, we were just kind of doing a cross-sectional study during the COVID era, and so I don't know the answer to that, but I think Kirsten might know if kids are more into it given the situation now.
I mean, basically, I sometimes use the phrase, robots and children is a marriage made in heaven. There is the occasional child who doesn't like robots, and when I say children, from very young 3-year-olds to also later teenagers. Of course, teenagers might be more interested in the technological aspects, you know, a robot as a gadget, or a robot that they play games with. But I mean, certainly there is the occasional child who maybe doesn't like a robot initially, but then maybe hears from their friends that the robot is cool, and then they interact with it. Adults and also older adults might be more cautious initially, which also puts the burden on us, the researchers or the developers of this technology, to introduce this technology appropriately. Because what we often find, whether with young or older people, they don't have any mental models of what is a robot. If they see a phone, they know it is a phone. Of course, phones have changed. You can now also, well, our smartphones now are basically little computers. It's different from when you had to pick up, you know, the phone. But still, we can use our phone metaphors of a mixture between a usual phone, a landline phone, and a computer. And then we have a good idea on what a smartphone is. With a robot, you have seen also in Michelle's videos, they come in all different shapes and sizes. People don't know what it is. And so very often we find that even if an initial reaction is cautious, not necessarily avoiding the robot, but just, oh, I don't know, I'm not sure if I want to use it. If you actually explain what it can do and what it cannot do and what the purpose is, and ask people for their preferences and how we can maybe accommodate these preferences, then this can change opinions. I think it's just that, again, people don't have a good idea or a mental model so that whenever they see the robot, they have an intuitive understanding what it is. So we need to also make sure that in the research that we are doing, that we convey this information. I don't know if this answered your question.
Yeah, so,
please, Dave.
Okay, thanks. Yeah, so related to your question around ER closures, I'll be honest with you, I don't think there's a lot of grassroots sort of work going on at the local level, unfortunately. This sort of struck in 2022 quite suddenly. I am actually tracking all of the ER closures in Ontario, and the primary cause of them is actually lack of nursing. It's actually not a physician shortage issue in Ontario anyway. I know in Nova Scotia, I think it's primarily physician driven, but in Ontario, it's a resource issue in terms of nursing staff. There are advocacy groups who are working to try and advocate to keep them open. I think one of the issues and one of the things that they should be working on, this is where they should be going, is more collaboration and coordination. And so I mentioned our Dean of Health Workforce earlier. She was telling me a couple weeks ago that there was a group of emerges in Southern Ontario that closed quite suddenly. And my understanding of the process is that the CEOs and the leadership try and keep the ER open as long as they can, and at the last minute when they cannot staff it, they have to put out a notice to the community that they're going to close. And unfortunately, this happened in a grouping of communities in Southern Ontario where for over a weekend period, multiple communities in close proximity didn't have access to their ER or the ones in their next closest ER. So one of the things that we've been talking about is trying to increase the collaboration and the coordination amongst the ERs. Now, if you have one ER that's going to close, why not coordinate with the ERs around it? You can share resources, right? The communities are relatively close together. Nursing staff, physician staff can be enticed to work in a community that's 20 or 30 kilometers away. My one caveat to this is that this will not work in Northern Ontario where the ERs are 100 plus kilometers away from each other. I truly feel that you can't close the ERs in Northern Ontario. They have to be kept open at all costs. And I feel that about Southern Ontario as well. It's just that there is a little more flexibility in terms of the system and the geography. So.
Thanks very much. I'm getting the signal, but I'm going to take a point of privilege to ask if we could get a microphone to Elder Henry. And while we do that, again, wanting to thank the panelists for the great insight, the amazing research, highlighting the power, both the challenges, but also the opportunities to be able to work together and really be able to come up with some novel solutions where, again, the technology is not the panacea, but an opportunity to then co-develop. And I'll share with you that in preparation for this panel discussion, we actually had a number of different discussions, and it was absolutely fascinating. So I think part of in the spirit of what we want to accomplish today is to, again, now you know who they are, you know the kind of work that they do, and we encourage you to reach out and really follow up and network and pursue those questions. So the reason why I wanted to ask Elder Henry to have a moment is that, in that sort of spirit of truth and reconciliation and the calls to action, I've been very fortunate to be able to get to know Elder Henry and really appreciate the indigenous ways of knowing. I wanted to actually get your opinion and hearing about this technology and the opportunity for social robotics. We talked about acceptability, penetration into different communities. What is your reflection or advice for our panelists as far as whether this is a good thing and how best to maybe approach it and integrate?
Oh, thank you very much. I listened intently to the presentations, and in my mind I was thinking about before even Canada became a country, United States became a country, there was relationships that created a level living standard for all people onto this continent. And we have treaties and we have relationships through our Wampum Belt teachings that talk about level of equality in our healthcare systems and our living standards. And when I heard about the technical genius that's happening, there is a section of society who's never really been a part of this process. We've been kind of subject to, I guess if you think of an indigenous person, what's the first thing that comes to your mind sometimes is poverty, as addiction and those types of elements. But if we gave it a little deeper thought and looked at what we've been able to continue to provide the benefit for all people on this continent, is we know how to purify water. We know how to respect the animals and plants that give us food and nourishment. And we keep promoting that. So I think, when we deal with governments today, institutions today, let's make that a little piece of our foundation, because the answers are already there. Mm-hmm. We've already created those when, Canada was formed as a country. And with that relationship building on our treaties and our relationship with the society that came to be, we wouldn't see as I heard a question on addiction, you wouldn't see these because the level playing field would be equalized through all people. Our health issues wouldn't be as complex as they are today because we would have that ability. So when we're looking at governments and looking for new ways of dealing with the issues we face, I think the standard has already been set. So let's implement that into our conversations. Those treaties are still valid. The Wampum Belts that we've signed together as signatories to them are still valid today, but we need to implement them. And maybe we've got to learn about them first. I think we've gone through generations of people not able to even know what those original agreements are. And I think that's what we can call indigenization, and helping people understand the level that needs to be spoke about more often today. And then we can alleviate some of those. We talked about the North and the issues that we have up there. Those would be generated better processes if we were able to do this. So I think that's a good piece of starting point for all of us, because it's there. We've all signed to it. Let's hold our governments accountable for that, and we'll see level playing fields a lot better. So thank you for the technology knowledge and your commitment to better standards for all of us. Miigwech.
Thank you very much, Elder Henry. And please join me in again thanking our panelists.
What's really exciting for me as a University of Waterloo researcher is to learn about not just what's happening outside my university, but also what's happening inside my university. I really appreciate those opportunities. I wish we had more of them. So this is great. Thank you to the Royal Society. It's my great pleasure now to introduce Dr. Heather Keller, who's our next speaker before our delicious lunch that will be coming. Heather is a Schlegel Research Chair in Nutrition and Aging at the University of Waterloo. And Schlegel is a household name around the University of Waterloo. One of our own former faculty members, Ron Schlegel, who has a real strong commitment between research, policy, and practice, and has several long-term care and other types of facilities in Ontario. And Heather is one of those chairs that's been supported by the Schlegel family. Her research is focused on improving the health and quality of life of older adults through food and nutrition. Frail older adults living in the community, recently transitioning from hospital, and/or living in long-term care residences are her primary focus, and her research is practice-focused with knowledge translation and implementation science components. Heather.
We're on? There we are, great. So it's wonderful to be here, and thank you for the invitation to speak today about some of my research. So as you see, I'm going to be talking about going from evidence to hopefully impact and change in specifically long-term care. It's one of the key areas, as Susan indicated, that I work in. I do work in other areas. Briefly, I'll just talk about them so you have a sense of the scope of my work. I do some work in hospital sector, specifically around trying to change practice. I'm a dietitian by training, and so all of my work has to have some application to it. It's not just theoretical. And so some of the things I'm doing in the hospital sector are trying to prevent and detect and treat malnutrition, which you may not know actually happens in up to one in two patients in our acute care hospitals in Canada. In the community, I focus in on nutrition risk screening for older adults specifically. About 1 in 3 older adults in the community have high nutrition risk. So this is a condition that can lead them to then having a fall or ending up in hospital. And I do work around trying to promote healthy eating for a group of people with dementia. I've got the cooking program we just started actually this past week at the care center. And I do some other work around exercise and nutrition with some colleagues in the dementia space as well as frailty space. But today I'm going to be speaking about long-term care and be talking about the foundational research that I did called Making the Most of Mealtimes and where it's led towards impact over the last several years. So let's talk about the evidence first off. So the Making the Most of Mealtimes was actually a monumental study because at the time there was actually not a lot of funding being put into long-term care in Canada, and we were almost received $1 million from CIHR to conduct this prevalence study. I can remember colleagues at the time saying, that kind of money for a prevalence study. But when recognizing that we need to understand the gaps in care before we can fix them, it was a worthwhile investment. I hope you'll see that as well through the work that I've presented today. So we wanted to measure what were people consuming in terms of food and fluid. Are they eating enough? And then secondly, what were the barriers and facilitators to that food intake? What could we do to actually support food intake in older adults? You may say, why are you focusing on food and fluid intake? We can target those, right? Malnutrition, almost all people have some level of malnutrition before they die in a long-term care home. So targeting malnutrition was not the focus, rather it was the food and fluid intake of individuals. So this is the investigatory team that was involved in this study from 2014 to 2018. And I'll just briefly talk about the study itself. So it's based on a conceptual framework that myself and colleagues developed called Making the Most of Mealtimes. This idea there's many factors that impact food intake. It's not just what's food on the plate, but it's the culture of individuals in the home, the meal quality itself. Do they want to eat it? Is it tasty? Does it smell nice? Does it have a right texture for people to consume? Meal access issues. In a long-term care sector, we have the issues of people having dementia or having had a stroke, being able to access food changes, as well as access of food outside of meals as well if they're not eating it at a meal. And then the mealtime experience. And this was the new part that I brought to this research area, recognizing that how we eat with others really impacts our food intake, especially when we think about older adults with dementia who look to others with cues around how to eat and what they should be eating. Layered on top of that was the recognition that the factors that influence our food intake are at the resident level, the staff and home level, and the government level. For example, we had I had a meeting before this. I came today and we're talking about the cost of food in long-term care. Right now it's over $10 in Ontario, but when we were doing this study, it was around $8. That's provincial policy that impacts on how much food can be put on the plate and the quality of that food. So you can see now how that can affect what people eat in long-term care. The study was 32 homes across 4 provinces, which again, magnitude-wise, was huge to do. We had 82 units or neighborhoods in those 32 homes and over 600 residents where we collected almost 2,000 variables per person. So it was a very comprehensive, huge data collection. Just to give you a sense of long-term care in Canada, these are people that require 2 or more hours per day of individualized care for bathing, dressing, etc. And some opportunity for rehabilitation may be there, but that's not consistent across homes, across provinces, or across even profit structures. Dietitians typically are in long-term care homes in Canada as a consultant service. They're not embedded in the home. They come in maybe once a week to do their work. So they're not part of the home care milieu when it comes to staffing. The key is that we focus on quality of life. We're not focused on extending life. We're not focused on cure. We are focused on quality of life. So this is, again, important. Thinking about food, it's not just about manage my diabetes, but food gives us pleasure, right? Food builds connection. And so how can we then promote that as well? So just a bit on the demographics. Most people in long-term care are female, over the age of 85 years typically. They have dementia, very high proportions, about 70% depending on what province you look at or what type of home. Many comorbidities, and depression is common. About 20 to 30% will have depression. Nutrition, we see issues of modified texture and fluid required for many people. In our study, we found about 30%, but some people have as high as 60% of modified texture foods. This is pureed food, minced food. And then eating challenges, very common. When you think about, again, these people are nearing the end of their life, functional changes, cognitive changes that impact their ability to consume food. So we found in this study that about 2/3 of the food that was being provided was being consumed, about 1,500 calories per day on average. And that's low when you think about it, right? When you think about our basic needs. And also fluid intake was on average only 1,100 milliliters a day. That's not very much. The base recommendation is 1,500 mils a day, so well below that. And some people, this is the average. Some people were down around 800, 700, 500 mils a day of fluid intake. We found that 9 of 22 nutrients, when we compared it to the recommendation that should be consumed by people that of this age and gender or sex, 9 of 22 are not being consumed at a recommended level. Actually, 50%, less than 50% of the requirement. So we had issues certainly with not eating enough, and perhaps as well not drinking enough, and then right types of food as well in terms of nutrients are not being consumed. We found that 4 to 5 were malnourished, so overt malnutrition. Not surprising, again, considering this context. And when I told you earlier on that acute care has about 1 in 2, depending on what ward or unit that you go into in a hospital. So it's not surprising, but it is perplexing if that malnutrition doesn't have to be happening, right? And so there's certainly some portion of people near the end of life, they stop eating. We expect malnutrition to occur. But for 2 or 3 years before that, we don't. And is that malnutrition actually speeding up the end of their life as well? So what influences food intake? And I have a little video. I don't know if people can play it when the text, people can play it for me in just a minute. But we identified that of all those variables that we collected information on, eating capacity and assistance with eating was a big driver of food intake. If you needed help, and this might be surprising to some of you, one-on-one help, you did fine. Because in most provinces, or in the provinces we include in this study, they had a policy around 1-to-1 or 1-to-2 feeding assistance, which means if you were dependent on someone else to eat, you actually got enough food. The group that was the problem were those that didn't always need help, and they sort of slipped through the cracks. You were either totally independent, you did fine, totally dependent, you did fine, but the large portion of people in the middle who were needing help sometimes, maybe by dinner time they were tired and needed help, they were slipping through the cracks and not eating as much. Food in the menu, not surprising when I told you that people are not eating enough, but the menu was part of the problem. So our menus were not even being developed at a level that was appropriate in terms of nutrient content. And then finally, the eating environment. And that's an area that I've tried to pick up further in my research. Maybe just, can we take a minute to play the video if you guys can do it for me? So we created this video after the study was completed about 2018 as a knowledge mechanism to support getting the news out. Is it going to show? It's coming? Okay. If you don't hear it, that's okay. It's just music, but you'll see the words on the top, and it highlights for folks the importance.
When you write,
oh, got to skip over the ads. It's on YouTube. You always have those two ads you have to look at, right? Anyway. Oh, can you show it too?
Yeah, just one moment.
There we are. Okay. At the bottom, you see, yep. Great. Thanks very much. So back to the slide. So as you can see, we've tried to translate that knowledge to a variety of people, and this was one of our mechanisms that we did that. Back to the slides. Am I going to have to go through all the slides again? Nope. Okay, great. Thank you. So now on to practice impact. So you'll see that, if you remember just in that video that you saw, we created actually checklists because people were saying to us, how do we make improvements? Immediately upon doing the study, people wanted to change and wanted to improve. And so an immediate result was trying to develop some checklists that people could use right in their own homes on a daily basis to think about how to make improvements. But we've tried to further promote this work through a variety of ways. Typical dissemination that you have with researchers. I won't go through all the detail there because this has been a very productive study and we made well use of that funding that we received, including things like fact sheets here that were used to be sent out to homes to support them in making changes in their home. The key though is that it took a while, and policy takes a while. It took a while, but we got actually best practices and policy in place, some of it based on this work, and specifically the one on the left-hand side, menu planning for long-term care. This came out in 2020 or so a couple of years after the finish of the study. And this was foundational. It came from Dietitians of Canada, OPDQ, which is the main partner in Quebec who leads dietitians in nutrition care, Canadian Malnutrition Task Force, which I'm a part of. And this group, for the first time, came together around this issue of meals and long-term care and how to actually provide high-quality food. And much of the data that came out of this M3 study actually was the basis for this policy. So it's driven actually across Canada change in how we fund food in long-term care, as well as how we plan food in long-term care, and thinking specifically about modified texture foods and the importance of those for individuals with dysphagia or swallowing problems. On the right-hand side in 2023, as part of the long-term care services standard that was created, it was just released in January, and I was the only dietitian that was on that team. And I think I was put on that team because I was making the most mealtime study. They knew all the incredible research that came out of it and had the opportunity to then intercede and put into that standard important things like care partners, family members should be able to go in the dining room and eat with their partner if they want to. We should have a home-like environment in the dining room. We should make sure that modified texture foods are as nutritious as regular foods, and thinking about the quality of the food being culturally appropriate, etc. These were new ideas that in the last standard were nowhere. They were absent. And so this is really a huge step forward, and nice to see the impact of that work. So in addition to trying to fill the knowledge gap, we're trying to fill the gap with interventions as well. And so I'm just going to speak specifically about a couple of key projects we've got going on in long-term care, trying to address these issues. So the eating capacity assistance, one of the key issues, as you remember, was low intake of fluid. We tried to create an educational program for team members in long-term care and retirement homes around offering fluid. The key reason people don't drink enough, they're not offered fluid. You don't have the capacity when you're in a wheelchair to go to a sink and get water anymore. There's no glass at a sink in your bathroom. So you need the offers of fluids between meals to actually consume enough fluid. So that's what Promote is about. With the food and menu, I work with some engineers. I was a past master's student of mine, became an engineering student, PhD, and she did some work around food intake in long-term care and how to measure it with machine learning. NID, which is nutrition disguise, is around the idea of enhancing menus with nutrient-dense ingredients, and then 3D printed pureed food, which we played around with a little bit as well. And then finally, the eating environment, focusing in again on training for team members in this long-term care scenario around Choice Plus. So I'll just briefly speak about some of these. Lots of tools and resources came out of this work. I won't go through them in detail, but some of these tools, for example, are new. They'd never been used before, and how we could then identify that the mealtime environment was hugely important. We developed these standardized tools, validated them before the study was conducted, and then used them in the study, and I've been using them since that time. So it's changed the way that other researchers are doing this work as well. And then, of course, some of the practice materials on the right-hand side. This is Nutrition Disguise, just showing you some of the materials we've created for folks. We've created for chefs how to make nutrient-dense recipes. They didn't know where the nutrients were in the food that they need to be including. We informed them of that. We came up with processes about how to make nutrient-dense food. You might think this is rather simple, but actually it's hard to do in a long-term care sector because many of the cooks don't cook, and so we're having to retrain them around that. And then on the bottom right-hand side, you'll see our attempt at making 3D printed carrots. And if you have questions about that, I can certainly answer them. But the challenge here, working with engineers, it was great to work with our engineer colleagues here on that project and a food scientist at the University of Guelph. The challenge was the technology isn't there yet. My part of the job was actually to talk to team members in long-term care and residents about what they thought of the technology. They thought it was really actually quite interesting and could be a good fix, but we're concerned about how slow it would take to make the food, issues around safety of the food, that sort of thing. So things we have to work on for sure with 3D printing as we go forward. This is the affinity technology that Dr. Fister did as part of her PhD, trying to think about how could we measure food intake more readily in long-term care. This is a big barrier to understanding who's eating what and when, and she tried to come up with machine learning and AI technology around that, and we're still doing some work on that with Alex Wong's lab. And then finally, Choice Plus. We've created this training program that we're actually just going for funding for to hopefully translate and evaluate in 15 homes across Canada with respect to changing practices in the home. So to wrap up, we need collaborative evidence creation. My team of people that are part of the M3 was nurses, we had speech language pathologists, dietitians, physicians, as well as environmental experts. And having that diverse expertise led us to having then a better solution, I think. Applied research, we need to have knowledge mobilization partners. We had the RA as a key partner to help us mobilize the work that we were doing, but also the homes, the provinces, the government, et cetera, to support uptake of that research. And that led to best practices and policy. And then finally, knowledge translation through interventions that are unique, that are innovative, that can change practice, and working towards evaluation and scaling that. So just to acknowledge various funders and other trainees involved in this work. And thank you very much.
We are about to have yet another amazing panel on the next generation approaches for improving health and well-being. And it's my tremendous pleasure to introduce Marina Moratzakis from the Faculty of Health. She is the Associate Dean Research there and an amazing researcher of her own. And come on up, Marina, with your panelists. And we look forward to hearing everything.
Welcome back, everyone. Thank you, Susan, for the introduction. I want to thank you I want to thank the morning speakers, actually, for providing such a thought-provoking series of ideas to stimulate a wonderful and meaningful conversation for global health. I'm sincerely honored to be moderating this next panel of incredible speakers, as Susan pointed out, for the theme, Next Generation Approaches for Improving Health and Wellbeing, Point-of-Care Diagnostics and Imaging, Wearable Devices, Sensors, and Assistive Technologies. So what exactly do we mean? Well, our speakers will discuss how the innovative development and use of technologies have advanced our understanding of health and have revolutionized how we screen, diagnose, and monitor health markers and biophysical measures, leading to impactful outcomes. As we journey through these talks with our speakers, I encourage you to also be mindful of how we put these innovations and how we generate access to ensure health for all. So I refer you to the exceptional bios of in the program for these speakers. But briefly, I will introduce who our speakers are. Our first speaker is Dr. Guy Faulkner, who is a professor and Canadian Institutes of Health Research Public Health Agency of Canada Chair in Applied Public Health at the University of British Columbia. Next, we will have Dr. Jeffrey Karp. He is our second speaker, and he is a professor of medicine at Harvard Medical School, Brigham and Women's Hospital. And finally, we have our own Dr. Alfred Yu, professor and Anserk's DC Fellow from the Department of Electrical and Computer Engineering here at UW. You might notice that when the speakers come up, we are missing one. Unfortunately, Dr. Karp could not join us in person today, and he will be online with us to give his speech or his presentation virtually. I will ask that our audience hold their questions until after all three speakers have presented, and then we'll have our fulsome discussion. Without further ado, I invite the three speakers to the stage to join me.
Sit down.
So at this point, I invite Dr. Guy Faulkner to present Wearable Technology and Physical Activity, a Powerful Combination.
Thank you, Marina, and good afternoon, everyone. I hope you enjoyed that lunch and managed to get a little bit of time outdoors for a walk. So I'm going to talk about the potential of wearable technology in addressing the global health challenge of physical inactivity. And of course, physical inactivity is a major risk factor for premature mortality and morbidity, and carries a considerable public health burden. And this issue is of global concern. The absolute mortality burden attributable to physical inactivity is greatest in middle-income countries, where, of course, the bulk of the world's population lives, and the highest projected healthcare costs are in high-income countries. And this recent paper in the Lancet Global Health demonstrates that in the absence of any change in the global prevalence of physical inactivity, we're likely to exceed more than 500 million new cases of preventable non-communicable diseases and over $500 billion in associated healthcare costs between now and 2030. So, of course, to address inactivity, we need multiple levels type interventions where we're addressing policies, we're changing the environments, changing social norms, but we certainly have a role for individual level interventions still. And that's really what I'm going to talk about today, about can we harness the ubiquitous nature of wearable technology to address this physical inactivity. And I'll talk about it in terms of a range of opportunities, and I just want to kind of call out to a colleague and friend, Dr. Eli Putterman, who led this paper and is also a new fellow of the Society. And I'm going to outline some of the benefits, potential benefits of wearables in terms of measurement, in terms of using it for research to assess naturalistic monitoring and ecological dynamics between movement and health behaviours, for understanding social and physical environments, but in particular looking at the potential for wearables in interventions for physical inactivity. And when I first moved to Canada in 2003, I was involved in at the time, what I thought was a very exciting research project called Canada on the Move. In 2003, Colloque said they were going to put pedometers into every package of Special K in Canada, across Canada. And of course, as researchers, we saw this as a fantastic natural experiment that suddenly all of these Canadians are going to have step monitors. They can monitor their steps. We can create a website called Canada on the Move. Canadians can enter their steps. We can set goals and we can intervene. Of course, what we found very quickly was that the quality of the pedometer was exactly what you'd expect to find in a cereal box. It didn't work, and that was the end of the project. But, move 16, 17 years later, of course, the majority of North Americans, in particular about 90%, have a smartphone, and all of those smartphones have a built-in accelerometer, and that measures physical activity. That can measure steps. And what we've looked at, when we've looked at the quality of smartphone technology for assessing steps, at least, is that they work, that they're pretty accurate. That this is a study that we did looking at the iPhone health app just in terms of steps, and you can see on the right, just about, that when we look at comparing what the iPhone is telling you in terms of the steps that you're taking, compared to a video actually recording how many steps you're taking, the accuracy is pretty good, at least at moderate to higher intensities. Where they seem to break down a little bit in terms of accuracy is at much slower speeds. So individuals, in this case, in our study at 2.5 kilometers an hour, that's where we saw a lot of misclassification. So suggesting that perhaps for individuals who have a different type of gait or a slower gait, that perhaps some of these devices or smartphones are maybe not as accurate. So that's one consideration. But certainly because of this technology, if everyone has a phone in their pocket, then we can use this data for measurement and surveillance. And we can perhaps avoid some of the limitations that we see through self-report and the bias that is inherent with self-report. And here's an example of, again, a kind of a natural experiment, actually with Katie DiSebastiano, who was a lead author on this, a former postdoc, looking at changes in physical activity as a result of the public health lockdown in response to the COVID-19 pandemic in March. So this was using the Participation app. So this is the PAC app. And again, you can connect the app to your health app in your iPhone, or you can connect it to a Garmin or a Fitbit. And so we can then extract data for everyone who downloads the PAC app of over 20,000 Canadians and looked at the physical activity before, during and after the initial public health lockdowns. And what you could see on the left is looking at the minutes of moderate to vigorous physical activity. And when lockdowns were initiated in March, we saw a very steep and significant decline in the minutes of moderate to vigorous physical activity. But 6 weeks later, this sample, their MVPA actually returned to baseline. On the far right is actual light physical activity, and we saw there, again, a significant decline in light physical activity that remained suppressed 6 weeks later. And that kind of makes intuitive sense. This is a type of habitual activity of walking to work, walking around at work that you might expect to see. So again, here's an example that we can use this type of data to actually evaluate and use in surveillance efforts. Given that these measures, smartphone technology and other wearable devices are relatively accurate, we can also use them for a range of research studies where we might be interested in looking at the relationship between physical activity and other health markers. An example of it is a current study just launched in Vancouver, where I'm interested in mental health as both an outcome and a determinant of physical activity. And in this case, we're working with colleagues who are using transcranial magnetic stimulation as a treatment for depression. And because of the wearables, like a watch that I have, an Apple Watch that I have, something that I can wear 24 hours a day, 7 days a week for 6 weeks, we can actually look at long-term movement behaviors in terms of this treatment period and have a look at the relationship between treatment response and changes in physical activity. Do we see a change in physical activity before we see a treatment response in regards to depression? Is it physical activity potentially a biomarker of treatment response? We can also, by using other methodologies like ecological momentary sampling, start to look at perhaps the bidirectional relationships between how people feel and physical activity over time. Do we feel good? Are we more likely to be active? If we're more active, does that reinforce feeling good, and so on? So a range of research questions become possible through this technology. We can also look at understanding the relationship between physical activity and the social and physical environments. Where do people engage in physical activity? Who do people engage with physical activity? Can we look at social units? Can we look at multiple devices being worn in a family unit, for example? Do more active parents have more active kids? Using the location data, we can look at the relationship between where you are and the amount of physical activity you're doing. Also, just a kind of, somewhat kind of an interesting study done in 2019, looking at the Carrot app, which I'll talk about shortly. This gave you a prompt when you were within 200 meters of a pharmacy to alert you to get a vaccination. So it not only increased steps to go to that pharmacy, but also kind of use the spatial data within the phone to prompt behavior change. So the final kind of aspect I want to look at is the actual use of interventions and using Carrot as an example. So when we use apps, we can also link those apps to your smartphone, your health app, so we can link to the physical activity data. But also within these apps, we can sprinkle in a range of other behavior change techniques because we're using prompts, we're asking people to monitor their activity, we're asking people to set goals. We might be even rewarding individuals for achieving those goals. And that was a premise of the Carrot app that some of you may have had. And so the Carrot app was linking goal attainment to receiving essentially loyalty points to a loyalty card provider, such as Aeroplan. And so the Carrot app had over 1 million users, had approximately 500,000 monthly active users in May of 2019, and had penetration in 3 provinces and territories. So an example of a kind of an intervention which we might be engaging with 100, 200 people to an intervention that's engaging over 500,000 people. Does it work? Certainly we found that short-term interventions, we saw some increases in physical activity, but this is just some data of the first year looking at over 50,000 Canadians and looking at over a year. So again, moving away from a short-term intervention, does this have a long-term effect? Yes and no. On the left-hand side, we have what are called inactive users. So these were users who are doing less than 5,000 steps a day when they started using the Carrot app. For those individuals, we saw a significant increase in daily steps that persisted 1 year later. On the right-hand side, we have the active users who are doing more than 5,000 steps at baseline. We saw no significant change over a year. In fact, we saw that what you'd expect to see, some seasonal variation that we didn't see in the inactive users. Another piece here is that there's an interaction with engagement. So how often were people actually using the app? And we saw, of course, the biggest change was in the bottom left quadrant with highly engaged, low active users. We saw on average something like a 2,000 step increase 1 year later, which at a public health level is, I think, quite a major impact. But there are some kind of issues and limitations about that I'll come to. Just to flag that, perhaps one of the areas that is receiving significant attention at the moment is the notion of just-in-time adaptive interventions, so that can we provide, through this technology, wearable devices, can we send messages or notifications when to intervene? So an example is, again, your Apple, if you have an Apple Watch, that there'll be, if you're spending too much time sitting, it sends you an alert to break up your sitting time. So using this type of initiative or intervention approach might be able to deliver the right type of intervention at the right moment for individuals. So we have certainly some opportunities that using these wearables for measurement, and for intervention, and for advancing research. Certainly there are some challenges. I think we initially talked about some of these devices as being objective measures of physical activity, and of course they're far from it. There are many subjective decisions that researchers in particular are making in terms of how we clean the data, how we analyze the data and interpret the data. There are issues, of course, around data storage and security and privacy. Of course, accessing the iPhone data from over 500,000 Canadians. You can consider some of those implications. But also, I think more practical issues around engagement and the user profile. So again, just some other examples on the left-hand side here is really just a long-term usage patterns of that Carrot app. And again, you can see, and this is a sample of a subsection of 46,000 Canadians, you do have these super users. So you do have a significant portion of people who are using the Carrot app most days of the year. But you've also got upwards of nearly around 50% of the sample who are barely using the app or using it very intermittently. So of course, these types of interventions are probably only as good as the engagement is. And that is a continual challenge for researchers working and practitioners working in this space. The other one is just on the right-hand side, and this is data from the Participation app. So again, the Participation app largely operated on these competitions and challenges, and it would ask you individually or to form a team, and let's take 1 million steps across Canada in the next 4 weeks. And we saw every time this type of challenge was conducted that yes, there was a significant increase in steps, but about halfway during the challenge, we started to see the effect waning. And by the time that the challenge had finished, everyone was back at baseline. The other question that you won't be able to meet out here, but on average, the PAC app users are doing, on average, 150 minutes of moderate to vigorous physical activity a week. And so one of the kind of lessons that you learn in wearable kind of research is, you know who uses wearable devices? Very active people. Very active people love physical activity apps and tracking their activity. So again, we do have a concern that, of course, there is issues around access, and is there the potential to widen health disparities, not only in terms of who has access to the technology, but also how do we ensure that we are helping individuals who perhaps most likely to benefit from these types of interventions are actually accessing them as well. So thank you very much for your attention. I think that I've touched upon some challenges and limitations, but certainly this is an exciting area for research to try to understand how do we effectively harness the ubiquitous nature of wearable technology, but in a way that helps people move more often. Thank you very much, and certainly thank you, of course, for all my collaborators and students in the Population Physical Activity Lab.
Thank you, Dr. Faulkner. This was a highly insightful talk, illuminating and leveraging a common product to many of us to educate and empower people to understand mobility and promote greater activity towards healthier communities. We'll now shift our thinking in the next talk, whereby we acquire knowledge from our environment and apply this knowledge to completely distinct problems. And so with that, I will introduce Dr. Jeffrey Karp. I'm not sure if we need a little bit of time to get him set up. Oh, there he is, fantastic. And Dr. Karp will be presenting towards accelerated medical innovation. thank you so much. My institution requires that I disclose my conflicts of interest before I give talks, of which I have many. I have co-founded several companies that have spun out of my lab, and I hold equity in those companies, and I'm an active consultant in them as well. And I wanted to just to start off by thanking all the tremendous people that I've worked with in my laboratory and collaborators over the years. I really think you know, these human-to-human interactions are just so important, and I just really cherish all of my meetings with them, and I've just learned so much from them, and I'm just really grateful to work with so many wonderful people from all over the world. I want to tell you a story that goes back to August of 2009, when Dr. Pedro Del Nido, who's the chief of cardiac surgery from Boston Children's Hospital, reached out to me with a problem that he was facing, which is septal defects. So these are holes in between the chambers of the heart. And he was saying that he goes to treat these infants, and sometimes the tissue is just so fragile, it tears. And there's devices that work for adults, but you can't simply downsize them because these are permanent materials. And as the child heart is growing, it just outgrows these devices. And it's something like 1 in 200 or 300 children who are born have a congenital heart defect, and a percentage of them require surgery. So he said, you know, can we work together to develop a solution for this? And so we brainstormed all kinds of different possibilities. And what we came up with was a patch that we could put inside the beating heart. It would attach to the surrounding tissue, the tissue surrounding the hole. And then it would immediately attach, seal the hole. Cells would grow on top of it from the surrounding tissue. It would form new tissue. Then the material would degrade, and the patient would be left with their own tissue sealing that hole, which could then naturally grow with the patient. So this sounded, you know, really great on paper, but was really an enormous challenge to get it to work. I think getting an adhesive to work inside a human heart, probably one of the most challenging environments inside the human body, because you have, you know, 60 beats per minute. So you have expansion contraction cycles. So the adhesive could delaminate. You have the force of the rushing blood going by. Every surface is covered with a layer of blood. And so you really need to get beyond that in order to get adhesion. But, you know, we were up for the challenge, and we started working on it, and, you know, making a little bit of progress. And then suddenly we hit a wall, and we just kept kind of stepping back and trying to get around that wall. And we just weren't making any progress. And this is something that happens pretty much in every project, where what happens, I think, is that, you know, we approach a problem and something doesn't work well. And when we step back, we rethink it, or we think we're rethinking it. And then we approach again. The problem being that often when we approach again, we're approaching with the same thinking, and we're expecting different outcomes. And I think this is really limiting us in terms of our ability to solve problems, not just in research, but I think, you know, far beyond research. And just to really highlight this example, I wanted to show you this problem that really occurred actually in Europe several years ago, which I think really illuminates the key point here I'm trying to make, which is, so we see here that we have this car. So the problem, I think, is quite evident. This car has fallen in the water. We have this crane. So the problem solvers are lined up here, and they brought in this crane. You know, probably had a few different options, and they start to lift the car out of the water. And things seem to be going well until the following happens. So one problem has become 2 problems, and the second problem is now even bigger than the first, something I can relate to in various ways. So the question here is, what are the problem solvers going to do next? And the answer is the same thing that all of us would do, which is bring in a bigger crane. And what do you think happens? The same thing. So I think the challenge for all of us really is, how do we break free from this conventional, repetitive sort of thinking that we tend to get ourselves into, this almost like low energy brain state where we're anticipating what comes next, where we're using the same thinking over and over and over again, even though we're not making much progress. And so in the lab, we've been working hard to try to find tools that can kind of disrupt these patterns and really bring in fresh energy and fresh ideas. And one of the ways that we've been doing that is to turn to nature for inspiration. And so it's this idea that every creature, anything that's living around us today, is here because it has solved insurmountable problems. And if a creature can't solve problems, then it becomes extinct. So I really believe that evolution is the best problem solver. And all we need to do is, go to the aquarium, take a walk in the woods, and gain some inspiration. And in the literature, there's a number of mechanisms that have been elucidated, research to discover how various creatures have solved problems. And I think by doing this, not only is it exciting, it's almost like this encyclopedia of solutions where new chapters are continually being written as we discover more and more, as our tools get better and better. And so we step back and we ask the question, what creatures exist within wet dynamic environments in nature? And we looked at lots of creatures. We looked at sandcastle worms that exist in the sea, and sometimes you'll see them sitting on rocks and the waves are hitting them and they're not moving. And then we also looked at slugs and snails. So sometimes you'll see a snail sitting on a leaf, it's raining and it's not moving, it's not falling off, or it's kind of walking along the ground and there's this kind of goo behind it. And so what we realized is that a number of creatures have things in common that allow them to attach within wet dynamic environments. And one is these secretions tend to be viscous, and anything that's viscous can stay put for a certain amount of time. So for example, if I put like honey on a surface, on a wall or table, it doesn't just wash away. You have to spend some time kind of running the water for it to rinse away. It has this viscous adhesive interaction. And I'll let you know why that's important in a moment. But the other thing that was interesting was that when we looked very carefully at the chemical composition of these secretions, they contained hydrophobic agents, and things that are hydrophobic can repel water. And that gave us the idea that, well, maybe we should consider our adhesive to be hydrophobic from the beginning, because most of the adhesives that were being developed at the time were hydrophilic, containing a lot of water to mimic the properties of tissues in the body. But hydrophobic might allow us to repel the blood away from the surface of the heart. Now, this didn't tell us exactly how to get this material to be super strongly adhesive, because we really don't want this to fail. And what we noticed when we were looking at ivy is that the mechanism was elucidated over 10 years ago. So ivy has these root hairs, and it crawls up a surface, and then when it finds a crevice, it inserts these root hairs into the crevice. It secretes a little bit of a glue, and then it dries up and mechanically interlocks with that surface. And so I don't know if anyone here has ever tried to pull ivy off a building or some sort of structure, but it's an incredible amount of force that's required. So this gave us the idea that if we develop a glue material, maybe we would have a precursor, and if we could get it on a surface, maybe it would infiltrate into the surface. And we use a lot of light activatable materials in the lab. So we thought, okay, maybe we could just shine light on it. Light can get into tissue, maybe 50 microns or 100 microns or so, maybe just enough to cure that glue inside the tissue and achieve a very strong bond. And so after a few months of really trial and error approach to find an adhesive that would do this, we actually found one. And this was a polymer material, like a plastic-like material that we had developed, a fully biodegradable and elastic. And here you can see we put this onto the heart tissue, and then we immediately cured it with the light. So it's light activatable. and then we freeze fractured it and looked at it. And you can see the interface here between the adhesive A and here's the collagen fiber in the tissue. And if you look carefully, you'll see that the glue is really just interdigitated in between the collagen fiber. So this really achieves like a really strong lock, mechanism, and and almost like a tissue like Velcro. And so we were interested then in seeing, how would this perform in experiments? So we did a number of experiments. One of the most challenging experiments we've ever performed in the lab is this one, where what we did is it was in a pig. We took a device Dr. Del Nito had in his lab, put the patch on the end, made an incision into the myocardium, pushed this up against the septum, which is where you would have these septal defects. We applied the light for 10 or 15 seconds, and then we removed it, and then we looked. And so here, what you're going to see is there's going to be two pigs. It's going to be a little fast, but we're using imaging here, and you can see that we have one patch attached here on the left and one here on the right. And this was about 80 or so beats per minute. And so what we did is we came back at 4 hours and we added epinephrine to increase the heart rate to see if the patch would remain attached. And sure enough, the patch did. You can see on the left and here on the right. And so we were really excited about this. We then, looked inside to see what the patch was doing, and it was, you could see here at the bottom, this patch was indeed attached, strongly attached. There's a suture here, which is actually part of the deployment mechanism. And so this was really one of the key first proof of concepts that we were able to generate in the laboratory that really helped us gain a lot of momentum. This project was really special in the sense that we had a really highly collaborative team that was made up of surgeons and material scientists, from all over the world. Nora here on the left is a cardiac surgeon who was in Dr. Del Nito's lab, and Maria is a material scientist from Portugal who was in my lab, and they were the two co-leads on this project. And so we also had the opportunity, actually, if I just go back for a second, just to kind of close the loop on this, we also showed we could use the glue to seal the carotid artery of a pig, the aorta of a pig. And we performed a number of other surgeries and showed this glue seemed to be a universal tissue glue. So I was giving a talk on this at the New England Aquarium one day, and there was a dentist, a oral maxillofacial surgeon from an animal hospital in Boston. And he said, I've run out of options for this dog that I've been treating. It's 10 years old. He pulled a tooth and it left a hole from the oral cavity to the nasal cavity. And he said he did 3 surgeries to try to pull some tissue over top of it. And it completely failed within a few days, because this is a bulldog. There's a lot of forces in its mouth. Sorry, I should have warned you for this little bit gruesome picture. But this is essentially what it looked like beforehand. And so he said, could we use your glue? Maybe we could seal this hole and it would provide some mechanical fixation, and then it could take on some of the mechanical load, so it wasn't all on this tissue flap, because we're going to pull the tissue over top, and that tissue was just tearing when he did it in 3 prior surgeries. So we took this glue, we filled this hole that you can see here, and then we were able to then kind of cut under this tissue, pull it over top, and suture it. And then this is the dog here. And then after the procedure, we came back and we were able to see that the tissue flap was actually still intact. So this actually worked incredibly well. And the dog, when it came in, was kind of not doing very well. It had stopped eating. It was really, really miserable. And I think what really, demonstrates the potential promise here is the before and after picture. So if you look carefully on the left bottom here, you'll see this dog was extremely unhappy before the procedure. But if you want to see what happens after the procedure, take a look at this. So we've gone from a really miserable dog to a happy dog. And this solution actually worked for a couple of years until the dog passed away from natural causes. And so since this time, I've actually visited Angel Memorial. I did grand rounds there, and we're actually now working on another project together. We also started a company called Pysium, and we were able to get regulatory approval for the glue component of this for vascular reconstruction. And we created devices to place this into many different places in the body. So we can spray it onto tissue here. You can see on the left, we've added a blue dye. In the middle, this is being applied underwater and with a vacuum-assisted device. And then on the right here, we can place this via minimally invasive procedures through like a trocar into many different places in the body. And you kind of see the light here. Actually, if you look here on the left, this is what the light looks like. We just shine it. It's LED light, and it's very safe. It doesn't get hot. In addition to the cardiovascular applications to seal blood vessels, which has been approved in Europe, and now we're getting going in the US, we have 2 trials underway right now for this glue for sutureless nerve repair and atraumatic hernia repair. And so for the hernia, we're actually doing this without tacks. So we found a way to use the glue, so we don't have to use these tacks, which cause a lot of pain because they're very stiff materials and they can move around. And then for the nerve, typically what happens is that you have a tube. When someone has a peripheral nerve that gets severed, you have a tube and you put the ends of the nerve into that tube and then you suture them, which causes more damage. So it's a very problematic solution. And so we came up with the idea that maybe we could do this without the sutures. And so the way it works is that we can actually make the tube out of the same material as the glue because it's photocurable. We can make kind of guidance topography, and then we can use the glue to glue the nerve to the tube. And so the idea is that what happens is that over time, this glue will dissolve away. It's completely degradable, and then the nerves will rejoin. And so this is undergoing a clinical trial right now in Australia. So in summary, I talked about a couple tools that we use in the lab, one bioinspiration. And so this is really about how, we start projects, we get going, and then when we encounter challenges, we then usher in fresh energy and ideas by turning to nature for inspiration. And then another is a tool that we use a lot is radical simplicity, which is really trying to minimize complexity at every possible stage, because we know that that has prevented the translation of many technologies to patients. And so it's something that we're always considering in every project that we work on. So I want to just thank everybody for your attention, and I look forward to the question and answer period on the panel. Wow, Dr. Karp, what an inspiring and stimulating presentation, encouraging us to break free from conventional thinking with your innovative approaches. And you certainly are looking to bridge gaps using nature as the inspiration in important gaps in medicine. For our next talk, Dr. Yu similarly takes a tech that has been widely used across medicine and is now creating an innovative approach to use this tech. I won't steal his thunder, and I now introduce Dr. Yu.
Thanks, Marina, for the introduction. Wow, building upon the very inspiring talk from the previous 2 speakers, let me now take an even deeper dive into engineering innovations. So what I wish to do is to spend a few minutes this afternoon to tell you a little bit more about our work on trying to develop new ultrasound imaging tools for next generation cardiovascular diagnostics. Now, overall speaking, we are quite fortunate to have ultrasound around as an imaging modality. What we're referring to is the use of mechanical waves that are well beyond the human audible range, particularly in the megahertz frequency range for medical imaging purpose. And there's this nice fine balance between penetration depth and resolution, and has been very useful for various anatomical imaging applications. We also have the acoustic Doppler effect, which we can leverage for various blood flow velocity estimation purposes. So in the past few decades, we have seen a lot of success in trying to apply ultrasound for anatomical and flow imaging applications. The technology is mature enough these days where you can even see 3D images, in this case of fetus still inside the mother's womb. From the engineering perspective, there's also a lot of progress in trying to bring ultrasound to point-of-care diagnostic applications. So there has been a lot of technical advances in IC technology and also various embedded system design approaches. And nowadays, we see all these portable handheld scanners that can be used widely, okay, for in point-of-care settings. But then, whenever we talk to our clinician friends and they throw us a problem, hey, can you try to do this for this particular cardiovascular diagnostic application? Our answer typically is like, sorry, the technology is not ready yet. And like the issue at play here is like clinical scanners, they can't really consistently track dynamic events. I'm going to illustrate here through this carotid imaging example. Now, when we are trying to look at flow that is providing blood up to the brain, right, flow will pass through the common carotid artery or CCA branch there, and will split into the two branches, the internal and external branches, and when it hits the bifurcation point. Even with the state-of-the-art scanners, this is what we actually can see. And I guess it's not that intuitive. All we are seeing are some red and blue color patterns, and there's some flashing once every second, which corresponds to the systolic phase of the flow cycle. Even for an experienced sonographer, it would take some time to interpret properly what is going on. So bottom line, there are quite a few limitations with the current technology. Number one, our frame is simply not high enough to consistently track complex flow. And the flow visualization is not that intuitive in the first place. And also, if our flow estimates aren't properly being derived, it's actually very difficult for us to try to quantify the complexity of flow or try to derive biomarkers that are of diagnostic interest. Can we do better than this? That has been the innovation thrust in our lab for many years. And indeed, there is a clinical need for new technologies. For instance, can we try to achieve early diagnosis of atherosclerosis? That certainly would be significant because atherosclerosis affects 25% of all adults. So we have been trying to look at this from a hemodynamic analysis point of view. Can we try to use ultrasound to detect blood flow and measure blood flow in a smarter way and a more holistic, comprehensive way, such that we can derive biomarkers of atherosclerosis? In order for us to be addressing this, we have been trying to understand exactly what is happening from a hemodynamic standpoint in a blood vessel and over the course of atherosclerosis progression. So in a healthy artery, this is what we typically have. Flow would be moving from left to the right, okay? And because of the fact that there is pulsatile flow and there's curved nature of the blood vessel, you would actually see some disturbed flow happening whenever we have entrance to a curvy branch of the blood vessel. And over the course of time, this will lead to disturbed flow-induced endothelial dysfunction, and it will favor the deposit of low-density lipoproteins. And at these points, if you take a look at the wall shearing pattern or the forces that are being exerted against the vessel wall, typically, we're seeing that at these curved branches, they have a low and oscillatory wall shear stress pattern. And they have been well recognized to be favoring plaque formation. And over the course of years, tens of years, we start to see plaque developing, and the game suddenly changes. The wall shear stress pattern changes from being a low and oscillatory wall shear stress. Now, because of the narrowing of the blood vessel, we convert it into a high wall shear stress scenario. And because of the high shearing force, it actually favors the dislodge of the plaque, and it increases the plaque rupture risk. And there are, of course, other complications here. For instance, plaque neovascularization, which means there's kind of like a foundational crack in the plaque, where there's a zippage of new blood vessels. And coupled with everything, the forces and the neovascularization, we actually would be seeing a high risk of embolus being dislodged, okay, and travel downstream, and it blocks blood vessels up in the brain and triggers an instance of ischemic stroke. So here, in the entire sequence of events, we can see that if we actually can try to map out the stir flow and wall shear forces properly, then that actually can be important for us to try to perform plaque diagnostics and monitor the risk of stroke in a more preventive way. So can we do that with ultrasound? Specifically, can we do atherosclerosis monitoring, complex flow mapping, wall shear force mapping with ultrasound? And the answer is yes, we can. And our innovation model in the lab has always been to try to design things from first principles, to build various hardware, to implement them in real time, test them, and try to deploy them for various applications in clinical practice. So on the algorithmic development side, we've been trying to develop various new advanced imaging algorithms where we'll be trying to derive flow factors from specialized firing schemes, which I'll explain a little bit more later on. And we've also been trying to develop new wall shear stress mapping tools and render them synchronously with flow factor maps. We have also been trying to develop techniques such as Doppler ultrasound bandwidth imaging to try to observe and visualize flow turbulence, as you can see in that video there. For these new imaging techniques, we've been trying to make sure that they can be implemented in clinical practice. So real-time implementation is something very important, and it's an essential part of our engineering effort. So we've been developing various open platform systems, GPU beamformers, and even for some of our AI-enhanced imaging work, we have been trying to apply edge computing solutions to facilitate this. Before we deploy them for clinical practice, we'll be testing them with various phantoms that we develop in our lab. There's the spiral flow phantom model. We also have various carotid phantoms and aneurysm models that we have built in the lab. And on the deployment side, we've been active in both the clinical translation and also the commercialization aspect in collaboration with the ultrasound industry. So various imaging modes that we've been developing in the lab have been commercialized and been implemented in next generation ultrasound scanners. Let me spend a minute here just to talk a little bit more about a couple of the new imaging techniques that we've developed. The first one that I'll be sharing with you is something called VPI, vector projectile imaging. What it is a high frame rate imaging tool for complex flow diagnostics. The general idea here is that we'll be trying to achieve time-resolved tracking of multi-directional flow. And the technique that we are trying to deploy here is multi-angle vector Doppler, where we shoot ultrasound from different angles, beamform them and receive them from different angles, and try to derive flow factors accordingly. And if we can do everything consistently, this is what we actually can see for the case of the spiral flow phantom model, where you can see that flow comes in from the inlet, spirals 3 times through the loop, and gets strained out at the center rather consistently. And also for the carotid bifurcation example, you can see that flow when it hits the bifurcation point, it will split into 2 branches, and you can also see that at the carotid bulb region there, there's a bit of the flow recirculation. So I'll tell a little bit more about the nerve fund in the lab. So we've been doing all these like open platform systems, and essentially what we do is we try to build our own platforms, because many of our techniques they are not suitable for implementation on current embedded systems that have been used in clinical practice, given the fact that there's just too much miniaturization happening that we cannot really readily configure the system operations. So we've been trying to come up with our own open platform systems such that we can try to collect all the channel raw echoes from the array front end and try to collect them and digitize them through the analog to digital converters and packetize them through the FPGA and send them to the back end for real-time processing on our FPGA on our GPU platform. Here's kind of like an imaging demo that I wish to just quickly show you. What we're trying to do here is a live vector flow imaging. And what we are trying to do here is this live mode, it's useful for the sonographer to try to navigate to the imaging view of interest. And then once you've locked down on your imaging view, you can press the freeze button, and then it will trigger on-demand replay at high frame rate in slow motion what is really happening, okay, in the imaging view of interest in terms of its complex flow patterns over the past few seconds of data that have been stored in the image buffer. So we have been trying to take things forward from there, trying to translate them towards clinical practice, seeing things that have not been able to, we are not able to see. And one of the cool experiments that we've been doing is trying to see how VPI can track complex flow in a case where we actually have a lower body negative pressure stress being applied. So in this case, what happens is that we will be subjecting the subject into this vacuum chamber. We will suck out all the air to induce a lower body negative pressure environment. And in this scenario, what would then happen is that there's going to be reduced blood flow back to the heart. So the cardiac output to the upper body is reduced as a result. And if we try to take a look at the blood flow velocity in the carotid arteries, we actually will see that there's a decrease in the flow velocity in the common carotid artery branch and also in the external carotid artery branch. When we try to apply factor flow imaging, this is what we can see. At baseline, you see a typical blood flow pattern that you already have seen a couple slides ago, where flow was split into two branches, and then there's a bit of a recirculation in the in the internal carotid artery branch. Now, if we are to subject the volunteer in a low body negative pressure environment, you can see that the flow complexity, especially in the carotid bulb region, has been increased as a result. So what we are able to see here is that with EPI, we're able to see very complicated flow dynamics. And in this case, this is due to the fact that there's low body negative pressure intervention being applied to the subjects. And with this initial success, we've been trying to think further. Okay? Now that we can derive flow factor maps very consistently, can we try to do something quantitative from this? Can we derive quantitative biomarkers out of this? So that has been our next technical challenge that we've been trying to address. And recently, we've been developing this technique called wall shear imaging, WASHI. It's essentially a duplex rendering of complex flow and the hemodynamic biomarker in the form of wall shear stress or wall shear rate. As I've already mentioned earlier, wall shear, that's basically the frictional force of the blood flow exerted on the vessel wall, and it has been well regarded as a key risk factor for atherosclerosis progression and the onset of ischemic stroke. As I mentioned earlier, we're going to see that there is low and oscillatory wall shear stress, okay, in the carotid bulb region there. In this case, we can see that in the bulb region, the magenta color actually appears quite often. It goes on and off, and that highlights the oscillatory nature of the wall shearing pattern in that particular location. And also, in this example, what is being seen is at the plaque cap, what the wall shear pattern looks like is that it's going to be very high wall shear stress pattern, given the fact that there's vascular narrowing. And so accordingly, at the cap, there's actually very bright wall shear stress that is being indicated in the video there. Well, in conclusion, I hope I have convinced you that there's tremendous potential in trying to apply ultrasound to cardiovascular diagnostics. But then we're still really just scratching our surface here, in that there's a lot that remains to be done. So from an engineering standpoint, we are still trying to actively play around with all these system miniaturization efforts. These will be crucial for point-of-care diagnostic applications. So we are already working on the next generation platform where we can actually downsize everything to that particular small system there that can be operated directly from a laptop. And like we've been trying to apply this to musculoskeletal diagnostics, which is pretty fun, in collaboration with Marina's group. So that's definitely something happening, and we're trying to, in real time, measure out what is the actual speed of sound moving through the tissue. And what we see is that there is actually quite a bit of difference in speed of sound, depending on how you're flexing your muscles. And now, as an engineer, I've always been trying to see how we can better apply our techniques for real-world applications. And so I'm very much looking forward to discussing with you further to see how we can possibly apply our solutions in different healthcare settings. This morning, we have heard that, yes, access to healthcare is a huge problem in Northern Ontario. Well, ultrasound being perhaps the only potential medical imaging tool that can be used in a point-of-care setting, how can we try to work things out in a way that can facilitate widespread use of ultrasound in primary care settings in resource-limited communities? So that has been something that we have been always trying to find out more for. So look forward to discussing further with you on this. And just before I conclude my presentation, I just want to pay tribute to all members of our lab. We are a happy family of nerds. We do a lot of fun things. We break a lot of things. We make a mess. But yeah, hopefully we're able to get things to work, okay, and be applied more broadly in various healthcare applications. And with that in mind, that concludes my presentation. Happy to take any questions from the audience. Thank you.
Well, I want to start by thanking all three speakers for sharing their thought-provoking work and ideas towards improving health. We saw lots of different examples and perspectives, and we'd love to have some questions from the audience at this point. And while you're settling in with thoughts and ideas, I think maybe I can start with one. Aligning with the theme of health for all, I wonder if each of our speakers could maybe discuss a little or elaborate maybe a little on the scalability, the point of access, and long-term sustainability of the areas that they each talked about. I know, Alfred, you've already touched on this a little bit, but maybe yourself, Jeff, and Guy can speak to this a little bit on each of the areas that you covered.
I can get started, I guess, and that's why I'm here, because I don't know how to scale up, and I'm very much hoping that we can try to work with various healthcare partners to figure out solutions. Now, along the way, I think there needs to be industry buy-in for this, right, as part of the partnership. And the challenge here is to really duplicate our platform and be able to send them off to many, many places for clinical studies. And that requires a lot of partnership, okay, from both the industry side and also from the clinical side. So it's a pretty complicated situation, I would say. And very much looking forward to hearing from perhaps people like Jeff, who has been involved in the medtech translation for a number of years as well, to hear his experience on how things have been like. Is Jeff around still, or?
I'm here.
Yep. Yeah, we'd like to hear your thoughts.
Okay, for sure. Yeah. Well, I think this is such a great question, and also such a great challenge. One of the things that we do in my laboratory is we really try to build an informal advisory board of people in the translational ecosystem. So, these would be people who are patent lawyers, corporate lawyers, reimbursement, regulatory experts. These are people who are manufacturing experts, so we can really address scalability. And we sort of think about problems in a way almost like a Venn diagram when we're starting. And so it's like the overlap between these circles. And so each one of the things I mentioned is a circle, and there are other ones, and then we look for that overlap. So when we try to define a problem, I think, often we think of, let's say, the biology problem or the technical problem or the medical problem, but there's also really, there's a big manufacturing problem, in terms of how we're going to be able to scale what we're doing. And I think most of the technologies developed in academia just haven't made it to patients. And one of the major reasons is because they haven't been scalable. And so this is something that we try to think about very early and often throughout our projects. And one of the ways we do this is that we actually engage people in the entrepreneurial ecosystem constantly to ask, even before we've kind of done experiments or after we've done even just some of the early experiments, we start to ask the question, do you think this can be scaled or not? In the case of the glue, this is something that I started working on kind of in the earlier days of my laboratory, and kind of learned a lot of lessons from it, because in fact, actually, when we started the company and we tried to scale the material, it actually wouldn't scale very well. We were making it 10 grams a day and using it the same day, but then when we started the company, we needed to make a kilogram or two and have it be shelf stable for a year or two. And it actually didn't work, so we had to go back and kind of make some changes, and luckily we were able to figure out how to do it. But I think, this really highlights a fundamental challenge, but I think that we can, in part or in a significant way, address by thinking about it very early and often throughout the entire trajectory of our project.
Thank you, Jeff. Guy, did you want to add anything to this?
Yeah, only just, you know, I mean, that's part of the seductive appeal of wearables for physical activity, is that it's already scalable. That again, it uses a statistic in North America of approximately 90% of people having a smartphone, then we can already intervene. And again, you gave the example of Carrot, which was intervening in any month with 500,000 users of the app. So it is inherently scalable, but the challenge, of course, is the longer term sustainability. As we all know, we also download lots of apps and we delete them very quickly as well. So they do require, there's a high churn, there's a high turnover, constant need to continually innovate, to engage app users. Certainly we do know that there are super users who do use apps for at least a year, again, with some of the data we've shown. But we've also tried to kind of start to rethinking that, again, does someone need to use a wearable tracker for forever, or even having a short-term 12-week kind of intervention that increases steps, for example, increases MVPA, and then promote some of these self-regulatory skills that allow people to become independently active, that don't rely on an app. That's where I think we need to look at, that I think having some kind of app that people will continually use for the rest of their lives perhaps is not sustainable, but we could look at short-term ways in which we use them to encourage, dare I say, use the word nudge, behavior change towards a more active one.
Great, thank you.
And maybe, if I may, I just want to comment a little bit more on the industry partnership aspect. Now, the ultrasound industry is relatively mature in the sense that, there are quite a number of companies out there. So sometimes they do have very short-term business interests that they want to fulfill, and for their for these more innovative solutions, they might not show immediate interest. In that case, what do? We also need to perhaps think about entrepreneurship initiatives where we can try to take some of these babies forward and try to grow the market through an entrepreneurship endeavor. And so that's perhaps another way of trying to scale up in this particular context. Yeah.
Great, thank you. That's okay, I've got more questions. Okay, well, I do have another question. I'm kind of curious, and this is again targeted for all three of you. Most of my work has mostly been on human participants, and with the target audience always being a clinical population or an aging population. And one of the caveats to the work that I do, one of the problems and challenges that arise, are the heterogeneity across populations. And so this often creates not just physiological problems, but translational challenges as well. So I'm curious as to some of the challenges that each of you have come across when it comes to the different types of populations you're dealing with. I know, Alfred, you're dealing with a clinical problem, so how does that apply to, let's say, how does the detection of atherosclerosis in an obese individual, is that challenged in the way that you approach this? The same thing goes with, Guy, some of the work that you've done. You've looked at wearables, and you mentioned that if gait is altered in some of these populations, how do you get across those challenges? And I have the same question for you too, Jeff, in terms of how the adhesive technology might vary from one type of population to another, and some of the challenges you need to address there. Who wants to start that one?
Maybe not me this time.
I'm happy to start. Yeah, no, I think this really has been a real challenge for the whole field of innovation, especially in the healthcare or life science field. I mean, often what happens is, technology is developed, it's tested in animal models, and those animals tend to be relatively homogeneous. And in some ways, there's sort of like the yin yang of that, because you want to be able to detect a signal. If you have a heterogeneous population, often it can be harder to detect a signal if you don't know whether you're on the right track. And so I think sort of, one of the kind of core approaches tends to be use more homogeneous type, most things we do in the lab are like very highly controlled. And then as soon as you move to, something that's living and then a human, things just become more and more and more complex. And so we use these simple systems and then we extrapolate from that to these complex systems. And, sometimes we get lucky. Sometimes we're not lucky and things fail. I think, we've seen this a lot with therapeutics that work in animal models, but then just don't work in humans. Or what we find is that in animal models it works for all the animals, and then you get humans and the drug only works in 15% of people or 20% of people. And then there's this whole other challenge there as well, because the pharma companies or big companies are kind of incentivized to have a drug that kind of everybody take, even if only a fraction of people really respond to it. And I think that's starting to change, but there certainly is a lot of sort of challenges and questions in and around the one that you just asked that I think is just important to think more about, and as we continue to make more progress, try to gain more insight and develop more models like organs on a chip. And, there's different, approaches I think that are being considered to address this.
Yeah, I think in terms of the clinical population application is to avoid wearable devices, that because of some of the concerns with the accuracy regarding things like gait speed, is that you would be using research monitors, accelerometers for physical activity. The wearable devices really are more looking at a population level, which probably can't take into account some of the nuances of some of those population issues that may affect not only wear time but also data that's being collected. But we're certainly very concerned or interested in that issue of engagement. Again, as I mentioned, with all of the data that I presented, the Carrot app data, the PAC app data, the majority of people who are using are already meeting physical activity guidelines. So they're very attractive to physically active people. And we see the better response with those who are inactive. So again, it's about how to increase that reach and get inactive individuals engaged with these types of wearables. The other thing is that certainly the PAC app, highly gendered. The majority of users are females of some of these apps as well. So that's a kind of another consideration. Certainly to an extent where the PAC app, we are almost considering, well, why don't we just focus this and tailor it for females, because the uptake was so primarily driven by that. So there are certainly kind of lots of research that shows the uptake of these wearables. There are some demographic differences that certainly we need to pay attention to if we are to kind of have an overall population effect, particularly for those who most need intervention.
Right. Yep. Good.
And from my perspective, working with different clinical populations has always been providing us with inspirations in our work. Now, as a researcher, yes, it's of course good to get things to work, right? And when things work, you get excited. But when things don't work, you should also be excited because it gives you new problems. And being an engineer, it's always cool to be trying to solve problems. And for instance, when we are trying to image obese subjects, we've always been running into this problem where the image quality just isn't that good. Okay? The physics is actually at play here because typically when we form images, we assume that the tissue is actually having a particular speed of sound. But then in obese subjects, because of the high fat content, the speed of sound actually vary quite a bit. And so accordingly, what we've been trying to do is to try to see if we can cope with this through the development of new techniques that would locally estimate the speed of sound and use that for image formation and beamforming development. And that actually has been somehow spin off into a PhD thesis, and we've been going a long way for a few years now on this. So when things don't work, it's actually pretty cool. And so working with different clinical populations, it actually gives us new inspirations, and it's been something in which we welcome. And hopefully they will give us more problems. to solve from an engineering point of view?
I wish there were more graduate students to hear you say, I wish there were more problems, and that you get excited about them. I agree with you. I think it does open the way for new and exciting research, because a lot of the solutions we come up with are not perfect, but they do lead to better solutions in the end. Shall we try again? Are there any questions? Oh, excellent.
I was just curious as to applications in low and middle income countries for, I mean, all of these technologies, especially wearable use and point of care. You think that there would be an uptake there? Can you just talk about efforts to make your work more global?
Well, again, I mean, I think certainly they're less accessible. Our devices, such as Garmin's or Fitbits, they have a cost. But I don't know the statistics on smartphone growth in lower middle income countries. Again, if you have a smartphone, there's an accelerometer in those, and so there is potential. But certainly some of these other devices that have a cost, I see as less scalable.
From my perspective, ultrasound actually has tons of potential for application in low and middle income countries. The challenge that I've been seeing is not to really get a system there, but we need to work on the infrastructure to make sure that the ultrasound units that are delivered there actually can be operational. Just like this morning, the keynote speaker was saying that, like, well, oftentimes it's not that we don't have these bioassay machines, right, or devices available. We just don't even have fresh water, right, and clean water to try to run these assays. So that's a problem, and that is what I see as the biggest challenge from ultrasound's perspective. There has been a lot of work. They are trying to bring ultrasound for use in low and middle income countries. Oftentimes, units are sent there, but the mains power, it's sporadically available through the day. That adds a lot of logistical challenges in terms of how these equipment can potentially be used. And so I think the key here is to try to work more closely together with government partners and to make sure that we have the right infrastructure in place. It's not just a matter of trying to get the units there, but we need to get the units there to be operational and useful. Otherwise, we can't really make an impact with these new solutions.
And I would just add, I think there's real opportunity for disruptive innovation here, because I think the current model just really the way that the current model works is that essentially, there's a technology that then requires an enormous amount of funding. You have investors who come in, they're taking a lot of risks. Everybody's trying to make money off of it in different ways, but it takes a while to de-risk it. Once it gets on the market, it ends up being very expensive. And so there's an affordability issue. And then what happens is that, it's only kind of like future generations where the technology is scaled even more, cost comes down, and then it can be more broadly applied to the developing world. And I think that the current model just in some ways I feel like we need to figure out a way and have more problem solvers around the table really thinking about how we can kind of flip this on its head, because I think that there's just more that we can do for providing accessible healthcare to all, and it's something that I've been thinking about, and just one sort of side thing, my wife and I towards this have actually started a non-profit organization to create a medical clinic in West Africa and Guinea, and we're actually just in the process of starting to build it, but we had to start with water, we had to build a well and a tower, and that was the first kind of step, and then we're hoping once that's built that maybe we can find ways to bring other modes of healthcare there and make it more accessible. But I think that it's really a big challenge. We just don't have enough people really around the table who are thinking about this and making it a top priority.
Great, thank you. I want to thank all three speakers again for their inspiring and insightful presentations and discussions. And if you can join me in thanking them.
Not for nothing, but I could get used to this musical introduction every time I stand up. I want it at home when I walk in the kitchen. Thanks so much. If everyone can take their seats, we're going to do our final panel of the day. And don't anybody be offended by this, but we have saved the very best for last. It's my tremendous pleasure to introduce Dr. Martin Cook. Martin is cross-appointed between sociology and the School of Public Health, and also has a senior administrative appointment in the Provost's office. Marty, I'm going to turn it over to you.
Well, thanks very much, Susan. Thank you, everybody. Welcome to our final session of the day. I'm honored to join you for this event, and I'm sure you found the sessions today to be as stimulating and inspirational as I have. So continuing with our conference theme, Health and Wellbeing for All by 2030, this session is Innovation and Health Equity, Improving Health Outcomes for Everyone. So we're going to focus specifically on innovations that promise to reduce inequities in health. So to that end, we're going to hear from three brilliant colleagues about their work. Although their approaches and the problems that they're addressing might be quite different, each of them is crossing boundaries and breaking barriers, including disciplinary, technical, and systemic ones, in order to move us toward better health and well-being for all. So I'm very happy to introduce our three panelists. First, Dr. Anita Layton is Professor and Canada 150 Research Chair in Mathematical Biology and Medicine here at the University of Waterloo. She's an internationally acclaimed authority and leading researcher in mathematical medicine and biology, and recognized for her pioneering contributions to mathematical modeling of physiology and pathophysiology. Dr. Kate Mulligan is the Senior Director of the Canadian Institute for Social Prescribing and Assistant Professor at the University of Toronto's Dalla Lana School of Public Health. In her work, Dr. Mulligan advances knowledge mobilization, policy analysis, and systems change for community health, social determinants, and health equity. And Dr. Margaret Mutumba is public health scholar and advocate and award-winning innovator with over a decade in maternal and reproductive health in sub-Saharan Africa. Dr. Mutumba is the co-founder of MedAtlas, a U-Waterloo digital health startup simplifying access to specialist healthcare in Africa, and she's currently at Western University. So please join me in welcoming our three panelists. Okay, so without further ado, I'll ask Dr. Layton to please come to the podium.
Okay, so thank you for being here. So what I want to do today, I'm very excited to, is to talk about how mathematics can be used as the new microscope in medicine to improve health outcome for everyone. Okay, now this is a blank slide because I want you to imagine someone having a heart attack. Okay, close an eye and think about it. So what do you see? Do you see the classic health heart attack like this, where a man is, bending over, clutching his chest in agony? Like this is basically the dramatic Hollywood portrayal of a heart attack, almost always depicting a man. And in fact, even though heart attack is the leading killer of women worldwide, the misconception that it is a man's disease still persists. And that misconception can be dangerous and risk women ignoring their own symptom. And in fact, heart attack symptom can be quite different between men and women. So for a man, if you're having a heart attack, you might be sweating, having pain in your chest, can't breathe, heartburn, indigestion. So yes, clearly you're having a heart attack because that's what I see on TV. For women, you might feel something different. You might feel dizzy, some uncomfortable pain between your shoulder blade, which is not where your heart is. You may feel really tired, can't breathe, indigestion. And if I'm feeling really tired, I might think I have COVID before I think I have a heart attack. Now let's talk about another global health challenge, hypertension. So hypertension affects about 1 billion people worldwide, and it accounts for more than 60% of the cases of cardiovascular disease. Now, when it comes to hypertension, the prevalence can be quite different among different ethnicities and different sexes. So hypertension has much higher prevalence among Black people compared to Caucasians, Asians, or Hispanics. And that is true in both men and women. And you see major sex differences in prevalence of hypertension as well. Before menopause, women tend to have lower blood pressure compared to men, but then the opposite becomes true after menopause. Now, for premenopausal women, we are less likely to develop hypertension, as you can see in that chart over there, compared to men of the same age, but then that female protection disappears after menopause. And you see the same sex difference in pretty much all ethnic groups. Yet, hypertensive men and women are often being treated using the same approach. And that can be a problem. Now, because we don't fully understand the sex differences in mechanisms that control blood pressure, turns out fewer women attain blood pressure control, even though women are more likely to seek treatment, and we are more compliant in taking those drugs. So these data highlight the critical need to better understand the blood pressure mechanism, control mechanism in all ethnic groups, and in both men and women. And the data also cast doubt in the current one-size-fits-all therapeutic approach. Now, these gender biases and misconceptions, false impressions are by no means limited to heart attack and hypertension. In fact, this prejudice can be found throughout our healthcare system, from biomedical research to disease diagnosis to treatment strategies. So to fight against these gender and racial biases that exist in medicine, we want to make sure that the broader public are aware of the dangers in this knowledge gap and pay more attention. And those of us who do biomedical research have the additional responsibility to make sure that both genders are addressed in our studies. Now, given the time constraint for the rest of the presentation, I'll focus on sex differences, which is not to say that the other dimensions are not important. Now, you might be amazed by the extent to which historically women were neglected in clinical studies. So in 1982, the Harvard Medical School began a physician's health study, which studied the effect of aspirin on cardiovascular disease. So that's a pretty important question, aspirin. A lot of us take them. So that study recruited more than 22,000 participants. So how many of those are women? 0. None of them. They're all men. Now, the Harvard study was by no means an anomaly. In the 70s, the US FDA banned all childbearing age women from phase 1 clinical trial. I'm talking about childbearing age women, not pregnant women. So childbearing age women will include me too, even though I'm quite old. I have a child in college. She's a third-year student at Waterloo doing math. So, and I'm not pregnant, no, I don't think so. So I can participate. And that ban was lifted only quite recently in 1993. So is that a problem? How big a problem is that? So imagine this scenario. Let's say Health Canada approved a drug based on studies in chimpanzees only, no human tests, right? So chimpanzee and me share about 96% of our gene, right? So is that bad? I don't know. Would you be comfortable taking that drug? Probably not, because the differences between chimpanzee and human might, give you some unexpected and undesirable reactions. In fact, in 2006, there was a German biotech company that tested a drug called TGN-1412 on human volunteers after, doing primate tests, and the results were disastrous. even though that drug seemed to be harmless in primates, at high doses, it managed to send the immune system of 6 people into serious overdrive, near fatal overdrive, causing widespread inflammation and multiple organ failure. So that was not good. Now, granted, the physiological differences between men and women, one of you and me, are much smaller between human and chimpanzee. That is very true. However, there are still important differences between us. For example, a very, very simple example, men are typically bigger than women, right? What is the average, the average height of a Canadian man? 85 kilograms. Do you know how much I weigh? I weigh 48. So I weigh less than 50 kilograms. So a dosage that is calibrated for an average sized man might cause an overdose in me, and I do not want that at all. And there are also important differences in kidney function and liver function between men and women that will mean that our body may metabolize and excrete some of those drugs differently. So I hope I have convinced you that if you are a physician, you want to tailor your prescription, tailor your treatment to the individual patients. For example, if somebody walks in, you want to understand how your patient may respond to a medication that you're considering. Some drug may work better in men than women, some the other way around, and maybe Asian people are more likely to suffer from adverse side effects of certain medication than people of different ethnic groups. And you want to understand what is the best medication for this particular patient of mine. And if you're a scientist, you want to understand why. If you're looking at a particular type of disease, say diabetes, you want to know what drugs or combination of drugs are best for your patient, and if your patients are at risk for complications. And what I want to convince you today is that math can be used to help answer some of these questions, and I will show you why. So to combat gender biases in medicine, our group has been developing sex-specific computational model of physiological system, meaning that I have a model of a kidney of a woman, not just a human person. So I'll give you an example. I'll use blood pressure regulation as an example. So you don't have to understand what that is. It's just to impress you how complicated that is. So blood pressure regulation is a good example, I think, because it involves a number of physiological systems all working together. Rather complicated, and complicated things are perfect for computational modeling. I love them. So a computational model for blood pressure regulation can involve typically a large system of coupled differential equations and algebraic equations, describing different physiological systems and regulatory systems that work together to stabilize your blood pressure. So the model system that you want to represent in your model may include the cardiovascular system, obviously, the renal system, your kidney, the renal sympathetic nervous system, and the renin-angiotensin system. So the renal-angiotensin system is a hormonal system that helps maintain your blood pressure. So it can be described by these equations that, again, just to show you, there is math in there, and there are a lot of other equations that describe other things that are going on. So what this model would do is something like this. Oh, your blood pressure is high, so the renal-angiotensin system will tell the kidney, okay, you need to pee out more salt and water, get rid of them from your body, lower your extracellular fluid volume, and therefore lower your blood pressure. That's what it does. Now, even though sex and gender differences in blood pressure regulation have been known in the community for decades, most of the existing computational models for blood pressure are gender neutral. Gender neutral means, in many cases, a lot of the model parameters were based on measurements done in male, either human, men, or male animals. So in order to understand sexual dimorphism and its implication on hypertensive medication, our group has recently published sex-specific blood pressure regulation model. So there will be blood pressure regulation system for men or for women separately. So our model will incorporate sex differences in all of the relevant systems in here, including your kidney, your renal sympathetic nervous system, and your renin-angiotensin system. So sex-specific models such as ours will be useful for contrasting men and women's response to certain hypertensive stimuli, or to explain why is it that men and women may respond to different drugs differently. Very interesting. I like it. Okay, so here is one application of our model. Drug response simulation. So suppose you have a drug, and you want to know, okay, who are the responders? Meaning, who are the people after taking this drug would see their blood pressure drop as intended, and who are the non-responder? Because I don't want to give this drug to someone who's not going to respond. Now, to answer that question, you can conduct a clinical trial of a lot of people. But that is expensive, and maybe I don't have the money. So alternatively, you can run what I would call a virtual clinical trial. You can feed the drug to a cohort of virtual patients, and this is how you do it. You take the model, and then you can create as many as you want, 10,000 virtual patients, by sampling specific model parameters within the physiological ranges. So you have to pick them very carefully. You don't want to be crazy about that. So men and women tend to have different distributions for different model parameters. For example, men tend to have lower venous resistance, that bar over there. So the blue part represent men, so you see them are lower than the pink, which is the women. And men tend to have higher renal sympathetic nervous activity. And there are many other differences that I cannot fit in this slide. So by sampling a number of model parameters within the ranges, you can generate as many virtual patients as you want. Then you feed these virtual people drug. You simulate the administration of your drug in these virtual patients, and then you look at the response. Does the model predict blood pressure drop or not? Okay? And then you analyze the result and learn that, next time, as a physician, you see a patient coming in, look at the patient, do you look like this group of people? You're the responder, so I will give you this drug. If you look like this other group of people, I'm giving you a different drug. And that is how it works. Again, lots of fun. So I hope I have convinced you that individual differences are really important in medicine. And policymakers have begun the effort of closing the gender gap in medical research. In recent years, CIHR has been promoting the use of sex and gender-based analysis plus in healthcare research. And they acknowledge that both biology, aka sex, and society, aka gender, are important in influencing our health and well-being in distinct but also interrelated ways. So CIHR's initiative aligns well with our government's commitment to integrate sex and gender into its policies and programs, including the way that government-funded research is to be conducted. And let me conclude by saying that a comprehensive understanding of sex and gender's impact on health and medicine is the key to the ultimate development of gender-based therapies. And math can be a contributor. Mathematical analysis that incorporates, if not highlights, the importance of sex and gender and their differences can facilitate a larger effort of precision medicine. And the same can be said for race and ethnicity and other individual differences. And this is how math can be used as the new microscope in medicines to improve health outcome for everybody. Thank you.
Thank you so much, Professor Layton. That's a fascinating example of transdisciplinary work and very compelling. So next, I'll ask Dr. Mulligan, who I believe will not have slides. Excellent.
Thank you. And thank you, all of you. It means a lot to us to see you here in person. Thanks for hanging in. I hope that you can take a moment to acknowledge the people sitting around you and how meaningful it is to really be spending time together. Oh, look, my slides did come. So even better, I'm going to be using slides to help me talk today about an innovation in health that's called social prescribing. And it's a way to bring together community health and community work on the social determinants of health with health systems. So these are what the World Health Organization calls the 6 building blocks for health systems. They're something that you're probably quite familiar with: leadership and governance, financing, human resources, information systems, and so on. And since I've already mentioned community, you might notice that that work of community, that work of action on the social determinants of health is missing. It's missing from what we think a health system is, what we think a health system does. And as a result, we end up with a healthcare system that looks a little bit like this. This is a map of healthcare spending here in Ontario in 2018. You don't have to worry about every little bit of spaghetti on the spaghetti diagram, but the thing to pay attention to is the most expensive items, the places that show where we are putting value in our health system. What do we value most? Where do we spend the most money? Hospitals, physicians, prescription drugs. Okay, and then some very tiny, tiny bits to things like public health or community care or Indigenous health and well-being. Even though we've got 30+ years of research now showing that between 50 and 80% of our health outcomes are determined outside of access to hospitals, physicians, and prescription drugs. In fact, hospitals and physicians make our health system look a whole lot like it did in 1867 at the time of Confederation, with the one innovation 100 years after that being Medicare, right? The prescription drugs. Now we're getting on to 75 years after that. We're ready for a new innovation. We're ready for something that really brings in all that work on the social determinants of health into our idea of what a health system is and what a health system does. And here's just one example. Last week I was at the first ever Canadian Caregiving Summit, where a coalition of people from all across the country went to Ottawa to really try to put caregiving and the work of caregivers on the national agenda. This is, for the vast majority of people, unpaid, unrecognized work that has to be squeezed into the rest of our lives when we're dealing with something that's extremely challenging. Caring for loved ones who are facing aging, physical ill health, mental health strain, and so on. And guess what? If we stopped doing it, our health system would notice. And their research shows that if all caregivers took a week off, well, our care systems would grind to a halt before noon on the first day. This is invisibilized labor that's propping up that health system made of 6 mainstream traditional building blocks. There, in fact, are more building blocks, but we don't recognize them, we don't fund them that way, and we don't connect to them well enough to keep us all healthy and well. Happily, this is starting to change. And in fact, just yesterday, the World Health Organization launched a new 3-year commission on social connectedness and health, recognizing that our relationships with one another, our relationships with our communities, and our relationships with ourselves really matter for health. And that it's about time that we put this on the global health agenda. And I've been working in this space for quite a long time now. Pre the COVID pandemic, this was a tough sell. Even people working in very progressive spaces would say, that's nice, but I'm busy trying to feed people or house people or deal with immediate emergency crises. Now that we've all been through periods of severe isolation and periods of real recognition of how inequitable that isolation has been and that exposure to disease has been, depending on our social circumstances, this is no longer a tough sell. We know this experientially, how important it is to be around other people, how meaningful it is to our overall health and well-being. So this is what it might look like if we went beyond those first 6 building blocks to really include the work of community and community health in our health system. So the innovation here, the technology, is the technology of care and connection. Right? Following up on that sort of feminist approach to understanding what health and well-being is and where our resilient and sustainable futures really lie. So this is a piece of work by Emma Sachs and colleagues in BMJ Global Health, and certainly the best examples of this work of being led by community health do tend to come from the Global South. That we need to recognize that household production of health is part of our health system. That's the care work we provide at home. That the social determinants of health matter, right? Which is, again, no longer a tough sell, but still not put into practice in our health systems. And I would include there the structural determinants of health, the causes of those social determinants of health. Why some people have better access to health care or housing or food than others. The work of community organizations, the work of societal partnerships, the work of community health workers, paid and unpaid, these underpin our health systems. This is what a health system truly looks like. And what we need to do is shift that spending to reflect this reality. We're starting to see more recognition of this here in Canada too. So just a week or 2 ago, the Chief Public Health Officer of Canada released her annual report on creating the conditions for resilient communities, and really zeroed in on some of those community organizations that are making a difference. And again, we saw this during the pandemic, that there were times that hospitals were not able to reach communities facing marginalization and inequity. There are sometimes very good reasons why, for example, Black communities or Indigenous communities or communities living in poverty may not trust mainstream health systems, right? There are historic wrongs and ongoing contemporary wrongs rooted in our colonial histories that make things difficult. But you know who does have good and strong and trusted relationships are those community organizations. The ones that are run by these communities themselves. The ones that recognize that in the community there is expertise, there are trusted relationships, there is embedded knowledge, place-based capacity, but what there isn't is enough funding and enough resourcing and enough connection to our health system to really support and celebrate those relationships and to really take an asset-based approach to understanding health. So instead of blaming communities for their different health outcomes or unequal health outcomes, we go to look at their strengths, to build on those strengths, to build better capacity, to use the expertise that's there in creating the conditions for health and well-being, creating the conditions for resilient communities that are ready to face the significant changes that come our way, whether it's the opioid crisis or weather emergencies with climate change or another pandemic, that we need to be ready for those, and that the data has really shown that the infrastructure, social and physical infrastructure at the very local level in neighborhoods is what's going to make the difference for our resilience. So, social prescribing is one tool, one technology we can use to really help make this happen. And it's really an umbrella term for approaches that link healthcare and community services in both directions. And now this work has been happening for millennia, right? Human beings have been taking care of one another for a really long time. And in health, there are some people, some professions, some organizations that are doing this really well. That, for example, when you go to see a physician in a community health center or primary care team, you might be getting a referral to local food support services or to social work to support with mental health. But it's really happening ad hoc. It's not systematic. And I think maybe most importantly, at the moment, we're not tracking the impacts of all this community-based work on our health experiences, our health outcomes, and our use of health services. So with something like social prescribing, we can get a supported referral to community services and understand how that's affecting and doing the labor of supporting health and health systems. So here's what it looks like. You have a client or a patient or a participant, a person, a human being who has both medical and social challenges, but also assets, gifts, something to offer, right? A whole person in relationship to their whole community and whole self. They encounter a prescriber. It could be a nurse practitioner, a family doctor. It could even be somebody working in the community side, even a neighbor or a self-referral. But that prescriber doesn't need to know everything about what's going on in this person's life. They just need to know enough that there's something going on that's beyond the capacity of the clinical health system to really support. This happens all the time in healthcare. So for example, people who are experiencing loneliness go to see their primary care providers more often. There is not too much that that primary care provider can do. But what they can do is make a referral to somebody who is a navigator or a community connector or a link worker, a peer community health worker from that community who does have the time to listen and the skills to make connections and to shift the focus away from what's the matter with me to what matters to me. And here, applying principles from health promotion, which really just means supporting people to take better control over their health and the conditions for their health. They can co-design, they can work together to come up with a solution. It might be a referral to a local arts club or theater group. It might be a referral to a friendly call or a group that goes walking in nature, right? We have lots of evidence that these kinds of interventions support our health, but they're not wrapped into our health system, at least not yet. So the person participates in a social prescription, and this is mostly for preventive and upstream health, right? We have some services in place for people in real crisis. This is to prevent people from getting into crisis. But then we have the data tracking. So we can link to electronic medical records about what happened with this person, what did they do, for how long, did it change their use of health services? Ideally, we're going to see that use of health services go down as people move even just one step upstream. For the odd person, their use of health services might go up because maybe they've been neglecting their health and need to be better connected into the clinical care system, and that's okay too. But we don't know that until we start tracking the data. And so that's one of the big innovations of social prescribing is formalizing, systematizing, and building a learning health system around the work of community referrals. And through this, we can start impacting things that people in community care about and people in health care about. So in healthcare, we often talk about something called the quintuple aim and the 5 things we really want to see improvement on. Enhancing the care experience for people, just having a better time, getting what you need, right? Having someone ask you what matters. Having someone focus on what's strong more than just what's wrong. The care team's well-being. We know that people working in health right now are under significant strain. Their mental health and physical well-being are they're really struggling with this. But the research shows that being able to do social interventions in health improves a sense of purpose for people, gives a sense of meaning again, and improves people's willingness and desire to be at work. And it also improves their workload because it helps with those people who are really keeping them up at night that they're concerned about, but don't have the clinical training or time to really help with. They know those people are going to be supported, they'll sleep better at night, and they can focus on the things that they are trained to do well. We can use it to advance health equity. And this is particularly true not only because we're addressing the social determinants of health, but because we can do this in very targeted and community-specific ways. So if you've seen one social prescribing program, you've seen, well, one social prescribing program. They look really different in different communities. And here in Ontario, for example, we've got a Black-focused, Black-led social prescribing initiative happening in 4 communities all across the province that will use Afrocentric principles and connect people to culturally appropriate, culturally specific, culturally safe services like Afrocentric hair care, for example, music and dance, connections to Black professionals in the community. These are the kinds of things that can support African and Caribbean communities in a way that's advancing their health equity. And we can measure and track the results and see if we're making a difference. We can reduce costs, again, by moving people into less expensive, non-clinical, community-based services, as long as we're supporting those services with the resources that they need. And then, ideally, we're improving population health, right, by taking this person-by-person, community-by-community approach. At the individual level and at the level of community services, we're doing this through self-determination, which means people get to have a say in what they think makes them healthy. And we really see this in a mismatch between, for example, what patients experiencing depression want and what their medical care providers think that they want. So medical care providers often want to reduce sadness in people. But what patients say over and over again is that what they want to is increased sense of purpose and meaning in their lives. There's a disconnect there where we need to listen more to what people actually feel is going on in their lives. So self-determination gives us that autonomy to make some decisions for ourselves about what we want to do. So you're not just going to be written a prescription, go for a nature walk if that's not your jam. You're going to work together to find something that does work for you. That you have an opportunity to feel relatedness and connectedness. That this sense of belonging is deeply and fundamentally human, and that our relational determinants of health really matter. And that you have a sense of belonging again in your community. And that means not just having friends and connections, but feeling that you matter. Feeling that your community that you belong to matters, is prioritized in policy and practice and so on. And you want to have a sense of competence, to be reminded that you do have the power to make changes in your own life that improve your health and well-being. And then lastly, one place where we are seeing significant improvements in health is when we have the last component of self-determination, which is beneficence, or the ability to give back to others. So when you go on to become a volunteer, or rediscover your sense of not just receiving from community, but giving to community, even if it's just sharing a smile and a cup of coffee with someone else, that's when we start to see big improvements in health and well-being. We want to know that we've got something to give. So, enter the new Canadian Institute for Social Prescribing. We've been around for a little over a year now and continue to grow with community and health organizations from all across the country starting to work together to build the infrastructure across the country and in collaboration with our global colleagues to make social prescribing a reality in our health systems, one that's strongly funded, recognized, and part of our learning health systems approach. We want to do that in a way that embeds equity and collaboration and the leadership of community. And that means, for example, that we pay participants with lived and living experience to be at the table co-designing alongside other kinds of experts. That we pay small community organizations representing those communities who face the biggest barriers to health and well-being to have the time to participate at the table, while the larger organizations participate in kind. So we make sure that we're able to fund EGAL to be there and make sure that to us LGBTQ health isn't forgotten, that it's prioritized in the work, that the Black Health Alliance is there, that the Ability Center and March of Dimes are there, that the caregivers are there, and so on, right? That Indigenous health leaders from across the country are there and have the support they need to create connections to this work where necessary and their own path where necessary under a self-determined approach. We're going to start with what's strong, which means we're going to grow where there's interest. And so maybe in this room, there might be 1 or 2 people who are ready to take their next step in developing social prescribing. That's where we go next. We're seeing in British Columbia, they've gone from a pilot project of 20 communities to a new announcement of 100 more community connectors across the province, starting with what's strong, learning from one another, and really growing. And then the part that I'm very interested in my research as we move forward is developing and using common measures. So we can start to recognize that all of this work in community health, it's not just a set of very small hyper-local initiatives. It's a quilt. And if we start knitting it together and demonstrating that together, in aggregate, we're making a big impact at that community health level in neighborhood and social services, in formal and informal community supports, then we'll be getting somewhere. So I encourage you to check us out at socialprescribing.ca and take your next steps. Thank you so much.
Thank you so much, Dr. Mulligan. That was absolutely fascinating. Real systems, efforts towards systems change, so thank you. So next I'll ask Dr. Matamba to please tell us about MedAtlas.
Thank you so much, Martin, and congratulations to making it to the last presentation of the day. We're at the home stretch, so hang in there. I appreciate being part of this panel. It's an honor for me to be here to share my work and that of my team on really transforming our research into innovative healthcare solutions for sub-Saharan Africa. So as I begin, I would like to start by first honoring and acknowledging that Western University, where I am situated, is land that is located on the traditional territories of the Anishinaabe, Haudenosaunee, Lenapewuk, and Choctaw nations. Lands located on the London Township, and these communities continue to be key contributors in shaping our life on their land. So thank you so much to those communities. So in my work as a healthcare researcher, this image of a health facility in Malawi represents a typical story of the many opportunities and pitfalls often seen and experienced in global health innovation. Research indicates that most health facilities in Africa lack the basic medical devices that healthcare professionals need to do their job. So what happens next? Well-meaning academic institutions, hospitals, philanthropists, charities, and international donors identify this gap in the health sector and often will come together to donate functional equipment, life-saving equipment to these facilities, with the hope that many lives will be saved as a result, only to return 5 years later to find that the donated equipment is in this dumping ground. This second image is of a young child who wakes up at dawn in Zambia to head to the swamps nearby to haul fish in. His tool of choice, this gigantic net, which is in fact a mosquito net that was donated to his family through a nationwide campaign to eradicate malaria in his community. However, in this community, nets are sewn together to form a gigantic sieve to bring fish in from the bottom of the swamps, a practice known as mosquito net fishing. Researchers, governments, and donors once again will come together to identify that a lack of mosquito nets is the major cause of malaria mortality, which can be solved by providing access to nets. The slogan goes, for $10, a net can save a life. This is true. However, for this young boy's family, it is a question of preventing malaria versus dying of starvation. These are some of the examples of innovations that were partly successful, but did not adequately achieve the expected outcome. So what happened here? We often see well-conducted research, clear understanding of the problem, and impact of the target population, but there remains a gap or a failure between this knowledge and successful implementation of health innovations in these contexts. Why is this the case? The reality is that when developing innovative solutions for these communities, researchers like ourselves, innovators, international bodies, often work in silos, using a vertical approach without fully understanding the local context and seeking input from the people and the communities to be impacted, especially in contexts where the people are considered to be poor or impoverished, uneducated, and in need of our health expertise.
The solution may be technically sound, but suboptimal from the people and context standpoint. Understanding context and centering people at the heart of all innovation is the key ingredient for successful innovation. In the first picture, we see donated incubators in an equipment graveyard, indicating that the local context was not considered. Questions that could have been asked include, is there local expertise in the form of biomedical engineers or technicians to ensure that this equipment can continue to function? Does the facility have access to continuous supply of electricity to power these incubators? How easy is it to install, repair, maintain, and upgrade this equipment? What are the hidden costs? Similarly, in the picture with the boy fishing with a mosquito net fishing is a growing problem, an unintended consequence to one of the biggest and most celebrated public health campaigns in recent years. Understanding the behaviors and lived experiences of target communities could have flagged many of these questions, which is why engaging and centering these communities is extremely important. It humanizes health innovation. Just like myself, having come from Uganda, even though I practice in public health, there is no way that I would come to Canada and start to implement interventions without understanding the local context, the structures, the way of life in many of our communities in Canada. So it's very unnerving, to say the least, that researchers, experts, and donors come from these parts of the world, not clearly understanding the local context on the ground and imposing health intervention based on what they think communities need. So for me, the application of this knowledge came with my doctoral research and innovation journey, where I was looking at how fertility care can be made more accessible and affordable in sub-Saharan Africa. Having managed over 7 fertility specialist hospitals, all private, in 5 different African countries, the cost of care was unacceptable for many of the patients I interacted with. Therefore, through my research, understanding the limitations of our public health systems, as has been highlighted earlier today, and my own lived experience, we decided to build a digital health startup company to address the inequitable access to fertility care in this region. We chose to do things differently. And we chose to do this by centering the voices and input of those who had experienced and been impacted by this reproductive condition. By putting people at the center of our research and innovation. Firstly, we went back to the community to share our findings with key stakeholders, inviting them to identify innovative solutions and design what would eventually become MedAtlas. On the left is one of the most prominent fertility patient advocates in Uganda. Mrs. Sembuya raised the alarm on the burden of infertility, a stigmatized condition, and often dealt with in the shadows. In the middle, a fertility nurse passionate about her patients and affordability of care. And on the right, the former Minister of Health, a strong voice and advocate for those seeking fertility care. Having these individuals and more made a notable difference for moving my research into an innovative solution that was culturally and contextually appropriate. However, it is the entrepreneurship tools that I gained from my time here at Waterloo that fostered a sustainable innovation model for our company. Moving between academia and entrepreneurship was a significant mind shift, and it was not an easy one. So the ecosystem here at Waterloo ensured that our team gained enough business knowledge required to build a meaningful business that could transform lives through healthcare access, engage diverse stakeholders beyond clinicians, but more importantly, create jobs. Consequently, MedAtlas was born, a digital health startup that connects patients anywhere in Africa to specialist care. Given the limitations of healthcare specialists on the continent, leveraging technology and the turn of the pandemic helped us develop a platform that could improve access and confidentiality to our communities. Again, With the input of the community, we adapted our technology to include diverse languages, reflecting the diversity of languages on the continent, as well as to include spiritual components. Many of our patients indicated the role of spirituality in their well-being as it regards to their reproductive health, and also introduce asynchronous support to compensate for the intermittent internet and power supply accessibility. And this speaks to the different levels of global health equity and access. It's one thing to create a digital platform that everyone can access, but it's very intentional for you to think about the languages, the way people look at health, and have those aspects integrated into the way you provide a service. So we worked hand in hand on this journey with our stakeholders from the beginning, and this facilitated the customization of our platform, ownership of the product, and building a solution that was once again culturally and contextually appropriate. Therefore, more and more, we are emphasizing the broader tenets of global health innovation. Often, we do well with the research, the innovation, and the healthcare system aspects. However, we need to leverage the tools of entrepreneurship and the rich cultural and contextual knowledge of those impacted by healthcare disparities to not only successfully design and implement solutions that will deliver long-term impact, but also to create entrepreneurs and jobs in the communities. This will reduce our reliance on donations, which has shown to not be sustainable. Understanding this formula in moving research from the lab into the community has been the cornerstone of the Frugal Biomedical Innovations Program at Western University. I have taken on the task of helping more researchers and students see their work transform lives in real time. This people and context-centered approach is one we have taken, supporting and working alongside innovators whose focus is to innovate and deploy medical technologies in remote parts of Canada and sub-Saharan Africa. Through this program, we have built partnerships with innovators in over 6 African countries and have launched over a dozen innovative medtech projects. Our partners lead in identifying the healthcare priorities and work with our teams to co-design solutions that are prioritizing minimizing of cost without compromising performance. Some of them include a teledentistry system in Kenya, a wearable system for Parkinson's disease in Nigeria, and a low-cost microscope option for malaria in Uganda. We hope that by centering people and culture in our technology development, we can demonstrate a stronger, culturally appropriate and sustainable model to global health innovation. Thank you very much, and I look forward to hearing your questions.
Thank you so much, Dr. Mutumba. Fascinating innovations. We have some time for questions, and we also have microphones moving around, so please just let one of our runners know if you have a question. Before that, I've been asked to prime with a couple of questions for the panel. As I've said, from my perspective, it seems as though all of these innovations that you're promoting to address health equity, it's all about crossing boundaries or reducing barriers in various ways. And all of you, in Margaret's words, are that you are properly doing things differently, in fact, or you're promoting doing things differently in order to address health equity. I wonder if you could say some words about, from your perspective in doing this work, what have the barriers been to doing things differently? What are the most important things that stand in the way or have stood in the way of this work? I mean, essentially, if this work was easy, it would have been done before, I would say. And so what are those things, if you could just highlight from the perspective of the systems in which you work and the types of challenges that you've addressed? And maybe I'll ask Margaret if you've had a chance to think about it to start.
Sure. Thank you, Martin, for that very important question. From our end, it's mainly the challenge around building meaningful relationships with marginalized communities. Because of the history of colonialism, because of the lack of appreciation of the knowledge and expertise that they bring not in our evidence-based way of understanding, but the fact that they understand their communities. Often their voices are not included. And because as academic institutions, all our projects have a timeline attached to them, it hinders our ability to build meaningful relationships, to then build sustainable innovations. So in our work, for instance, in our remote communities here in Northern Canada, we've had to really advocate that putting a time limit to measure success of a project is not fair, because a lot of damage has been done that has led us to this point. And so we need to give adequate time for communities, for researchers, all the multidisciplinary groups to build that trust back first, to see our innovation as an exchange. It's not us going in and giving them equipment. We too can learn from what they're doing. It's an exchange, it's not a one-way issue. And so changing that cultural shift in our academic way of innovating and doing things has been one of our biggest challenges.
Excellent, thank you. Kate, I wonder.
Yeah, so I mean, there are always challenges when you're trying to collaborate and build collaborations across boundaries. And so we have had a number of challenges. One of them is the sense of perpetual crisis in Canadian healthcare, that many people say, that sounds great, it would be nice, but you know, I'm busy doing something else that's more urgent. And so one of the reasons I really like social prescribing is that it's a lot easier to describe and use than, say, asset-based community development approaches that address social determinants of health. Like, I've lost people by the time I describe it in that way that maybe some community folks feel has more integrity to the concept. But if we can just deliver a tool, and clinical folks are very tool-based, they like to have a tool. If we can deliver a tool that makes their lives easier by a little bit, we don't have to start by changing hearts and minds. We can start by changing practices. And then what happens in a complex adaptive system is that they get feedback. They start to see that this feels good. They start to see that my patients' visits have gone down. They start to see that I know a little bit more about what's going on in my community, and so on. And then you're in a cycle of improvement. It won't be perfect at first, but you'll want to do more. And that's really what our experience has been, that people, once they try it, they like it, they want more of it, and it keeps growing from there. So I think that that sort of very practical approach can be really helpful with some of those sticky problems, that we don't have to convince everybody. And certainly there's sometimes resistance to having community engagement. I still hear feedback sometimes to say that's not science, or that's watering down the science, to have community voices in there. But our research and our experience shows otherwise, right? That we won't succeed unless we have some of these practical steps in place. So we're going to keep learning by doing and taking that implementation science approach. And that gives me some hope that we'll continue to, we will have barriers, but we'll be able to face them together.
Awesome, thank you. Professor Layton, your challenges are about disciplines, I imagine, but
yes.
Any thoughts?
So my work, is rather interdisciplinary, which is both challenging and a lot of fun. My background is actually computer science, not even math. But most of the time, the people I hang out with are MD and physiologists. And they're a lot more interesting to me than my math colleagues, to be honest with you. I learn a lot from them, and they are a lot of fun. So the challenges, I would say, would be, I need to be able to talk intelligently with them. You can build a model, but if it's not truly relevant, nobody cares what you do. Sure, you can present it at some, applied math conferences, but people who you want to use the model would not be there. And aside from that, there are additional challenges which that my biologist friend face. I talk about, you need to understand the sex difference. Do you know why, biomedical research have been pretty much limited to male? So it's not just clinical research that neglect women. If you look at animal research, preclinical research, typically, traditionally, they're all done in male animal. Well, why is that? Well, that's because females have menstrual cycle and fluctuating hormones, which, you would think, oh my goodness, that makes my results difficult to reproduce and maybe unreliable, right? So that is one problem. And then you wanted to do sex difference, that means you do have to repeat the experiment in 2 sets of animal, male and female. And guess what? You submit a proposal to your funding agency, it costs double. Are they going to fund you? Hopefully, but you can always hope for many things, right? So that is a major challenge, right? Your grant proposal is now twice as expensive as the other person who just have single-sex animal or, you know, more limited or something, right? So there are challenges. There are utopia where I want people to, you know, do the experiment, different sexes, different, you know, ethnicity if it's human research, but it does cost money, and I do not have an answer for that.
Great. Thank you. We have questions from the floor.
Gui, hello. I just want to start by saying thank you so much, not just for your presentations, but also for your work. I'm blown away by this panel, truly. And the question that I pose is very much out of just a genuine curiosity. According to, I guess, like current medical categorizations, I would be categorized as biologically intersex. And I'm wondering, and so I've been listening to your panels, and although we talked a bit about the inclusion of women, which it's horrific that we're even having to talk about that, of course. But then, in addition to, you know, we're talking about LGBTQIA+ inclusion, we're talking about the inclusion of potentially Black and brown communities, Indigenous communities around the world, where some of these communities do have higher rates of intersex individuals. I was wondering if you guys have any thoughts on the future of medical research and the inclusion of, you know, possibly making our screening of biological sex more comprehensive and more inclusive of individuals who might not fall strictly within those sexual categories.
Yeah, so that's definitely should be the goal that we're going for, right? So, you know, like I said, I focus on sex difference. I didn't even address gender much at all, right? So I was focused on the model, focused on biological sex, because that for me is the lowest hanging fruit. That's the easiest thing to do. I didn't talk about race because, you know, that is a lot harder to build models. Right, so I'm just speaking from the perspective of computational modeler. Do you know how I build a model? I need lots of data, right? I try to impress you with the little circle, little boxes, right? So each box requires a lot of parameter. How do you get those parameters? You have to cut animals up and, you know, do measurement. So I always build a model using rat data. So I start with a rat animal. This is a male rat, female rat. Rat, I don't know what the gender is, right? So that's a, you know, social construct that is difficult to define for a non-human. So I build that and then I translate to human. Why don't I start with you? Well, because I can't cut you up and get all the data. So we always start with an animal model and then you sort of translate to human. And that's why I have done much less work about other gender and about race and ethnicity. It's difficult to say, okay, this rat translates to Caucasian, this is more like me, right? Sex is easy, so that's why I did most of my work. We are trying to broaden out, you know, branch out because, you know, other dimensions, as I said, are equally important. They're more difficult, which is not to say that we shouldn't aim for it.
Yeah. Any other reactions?
Well, thanks so much for the question. And I think, you know, my work is more on the social side than the biological side. At the same time, it recognizes that unique and context-specific experience of health really matters. And so building trusting relationships in health in which we can have conversations about deep inclusion throughout your healthcare experience, and including research as part of that health experience for people, that we are increasingly inclusive of the span of human diversity, that matters, and that our differential access to power is inhibiting our ability to do that really well is a problem. So the more we can, from my perspective, help track and measure at that individual level, that's where we're going to start to see some progress, because we'll be able to demonstrate the difference in health outcomes, health experiences, connectedness to community, and so on, for intersex individuals in a way that's much more fine-grained than we've been able to do in the past. For example, and so I'm very hopeful that this will open up new ways to think about, you know, what they call precision medicine, that we can have that level of precision socially as much as we do clinically and in the research.
Thank you.
The only thing I would add is for the context that I operate in, we are going backwards. Unfortunately, the laws are discriminatory against, you have to be either one or the other. And unfortunately, what that means is a lot of folks who do not see themselves in those binaries go underground. And it's very unfortunate because then that means they have poor access to healthcare and therefore healthcare outcomes. But the value that we found in building MedAtlas is that because it's a digital platform and because we removed the component of having a video, for instance, we found that a lot of our participants were more comfortable accessing care because they did not have to disclose their sexuality. And also when you're talking about infertility, because the assumption is that it's female, on our application we found that a lot of males were accessing the platform, saying that this is the first time I've spoken to a physician about my fertility challenges. Because again, when we're talking about reproductive care, we only mostly talk about women and fail to realize that men also have their own reproductive challenges. So I think we have a lot of work to do. I think we can definitely learn from contexts like this, but that's where the power of technology can overcome some of these geographical differences that hinder access to healthcare.
Thank you.
Yeah.
We have another question from the floor.
Thank you for 3 amazing presentations, also blown away. My question is, I wondered if any of you had thoughts about the role of regulation or standards in ensuring technology is responsibly deployed for equity-deserving groups as part of the solution, not the full solution.
So in the context in which, again, I'm operating in, regulation has been slow. The technology is moving much, much faster than governments are able to develop regulation for. And so in a way, this is helpful as a startup because then you can quickly launch your idea and trial it. But on the other hand, it is dangerous for those who are accessing these services and they're not regulated in any way. I'll share that in our experience in building MedAtlas, because we're focusing on specialist healthcare, we wanted to ensure that all the members that use our platforms know that our specialists are certified. And so we shared that with our government regulatory body. But they felt threatened that we were doing the job that they were supposed to be doing, which is regulating the healthcare industry. But they do not have the capacity to do that, right? And so that's really the challenge we're finding with regulation, that on paper, many countries in low-resource contexts might even have regulation, but implementing it is a completely different story. There's a lot of gaps that happen there, and so we have to keep an eye on that and ensure that our innovations are not causing more harm. We have to self-regulate as a community. Yeah.
So, I mean, thanks for the question. I think it's a really important one. There is a known risk of perpetuating bias when we implement technologies in healthcare. And so it is something that we need to be really cognizant of when we're trying to advance health equity. One of the ways that we're trying to do this at present is using clinical practice guidelines as a bit of a sort of quasi-regulatory approach, that if we can start to embed practices around social prescribing, considerations of social determinants of health, and so on, into regular practice when it comes to diabetes care, for example. That when you're thinking about diabetes, you can think about what are the population level differences in diabetes for South Asian, Black, and white populations, for example. What are some of the determinants of those differences, and how might we start to really start addressing the causes of the causes? So we can build in connections to locally appropriate trauma-informed services and supports, for example. And that's increasingly what people want. So when I talk with Diabetes Canada, what people living with diabetes are asking for is not more education about the basics of dealing with their condition, but another person to talk to who gets what they're going through. And it can relate to what they're doing and can support them in a sort of a peer-to-peer way. So building in these kinds of things into the clinical practice guidelines is one way to make sure that we're doing it well. And when we think about broader access to social prescribing type supports and social supports and services, we need to be really doing the advocacy work around digital health equity at the same time. Some people don't have the same level of access to digital tools and supports, even to internet, broadband internet across Canada or in sub-Saharan Africa, or access to understanding and knowledge around the latest and greatest when it comes to AI applications in health and so on. So I think that the regulatory and policy environments are best served by dialoguing with practice as we evolve. And so really trying to make sure that those communities of practice, building a new system, incorporate that ability to speak to regulators from the work of practice and community.
Thank you so much. Well, friends, this concludes our final session of the day. Thank you so much for joining us, and please join me in thanking our presenters, Dr. Layton, Dr. Mulligan, and Dr. Mutumba.
What a crescendo, eh? To an amazing day. Told you we saved the best for last. They blew everybody away. Thank you so much. It's my tremendous pleasure now to bring back Mayangun, Sarah, and Benny to close us off for the day.
Okay. I'll get you guys down. Turn it around. One, two. Good afternoon. Welcome. It was a welcoming day to be with you, to feel good about what we've learned, and all the presentations were just wonderful. I really appreciate the knowledge shared today. This morning we began in a ceremonial mode. We brought the Eagle staff, which was carried by Jade Hill. And this afternoon, in closing, what I'd like to do is offer you a chance to look at some of our history. In the mid-1700s, indigenous people in this region realized that there was going to be a change in the environment of people coming to North America. And it became a little bit of a struggle with First Nation communities who lived primarily in the eastern parts of North America, because they were getting pushed out of their communities by the settlers that came. And by the thought of one chief who said, this is the time to stand up for the people that are being displaced. And one of our chiefs that we now know as Chief Odawa. Odawa is a word that you probably don't hear too often, but the capital of Canada is named after Chief Odawa and the people of his nation. So they've corrupted the word to Ottawa, and it really should be Odawa, because that's how it's reflected with the nation that call themselves Odawa, and Chief Odawa, who carried that powerful message, Chief Pontiac, who carried the powerful message of the Odawa people. And during a time when it came to almost to the battlefield, when the settlers were very, very, wanting to take land and resources that are here, Indigenous people started standing up and saying that, well, enough is enough. We need to keep our land sacred, and those who are intruding on our land, it's come to a point where we need to battle back. So Chief Pontiac carried a vision of taking over the forts that were built along the region. And he was successful in some areas, but what he did was acknowledge from all the people here in North America that they were encroaching on land uncomfortably, and at this point. So you might have heard of the Pontiac Wars in the mid-1700s. And he was successful in telling the British that we weren't happy with what was going on. And so there was a lot of changeover during that time. But what it resulted in was an agreement between our people. And so in 1764, there was a meeting in what we now know as Niagara, where a belt was presented to 24 nations that attended. And the belt was a significant move on behalf of the British government to recognize our nations together. You'll see in the belt here, the squares, which means our council fires. They're where we had our meetings every year, and we would pass presents back and forth to each other because we needed to up and make sure that our agreements were full. The two people that you've seen in the belt here are the indigenous people and the settlers that came here. You'll see that their hands are tied together. And you can see the council fires are set up in this manner because we had to move to different locations at different times during the years of this belt being enacted. So indigenous people, you wouldn't see us working in a square method like this. We always did things in a circle. You always seen our medicine circle, our medicine wheel. In our teepees that you'd see, the base of them are round. Everything that we look at in, I guess, our perspective is in a round setting. So I'm going to get you to try to connect the back of this belt together. You'll see that they align when you connect them together. And if you turn it around, you can see that they match together there the way they're supposed to. But this belt now reflects one of the first nation-to-nation agreements that we had with the settlers. And this belt being adopted or ratified in Niagara was adopted by the 24 nations of this region during that time, which meant that we would be looked at as a nation and not an underling of that nation. We were, I guess some people call this the indigenous Magna Carta in a sense. It's a matter of us having a real nation-to-nation relationship with the settlers that came. And inside that agreement was the fact that we were autonomous. We had our own healthcare system, our language, our religion, and all the things that constitutes a nation, and we would be recognized that way. And this belt that was ratified signifies that importance of building on the relationship of the original people of this land. Having the ability to share knowledge and to build a forward future with us at equal balance. And so this belt itself is still used in our courts today when we have to deal with governmental issues that affect First Nation people. I don't know if you've ever seen a wampum belt before, but that's exactly what this one is. And we call this, it could be called a few different words for it, but the Treaty of Niagara, the Covenant Chain, various other names that this belt carries within itself to signify the strength of the unity between the nations. And this all boils down to what today's topic was about. We're seeing disparities in indigenous health in northern communities and even here in the south. But building a relationship to grow what was already decided is something that this generation is going to have to take on now. We've gone through the period of residential schools, the murdered and missing women, who numbers are increasing every day, and 60 scoop children who were taken away from their families and taken away from their culture and language. So those days now have been seen quite clearly in today's society. But the fact is, how do we make the differences and changes to work on a better future together? So we refer back to our wampum belts to let society know that there is a route that we can follow. And it's based on our original relationship with the settlers who came here. And that includes education, health, economic equality. And if we did that, and what I would suggest for people that want to be allies with Indigenous people is to prompt your governments to live up to the agreements that were already made. Just because the time lapse doesn't mean that they've expired. It's that they're still signatories to the treaties that will create accommodation for all living people on this place we call Turtle Island. And if we did that, And if we prompted our governments to do that, you would see less health disparity, you would see less poverty, you would see less people living in conditions of addiction. Because we know if people have the basics of life and they have places where they can live comfortably, your overall mental health and well-being would be stabilized to a point where you would be able to have a better living standard in this country. And that's really what these belts were formed on. You wouldn't expect us to give up 220 million acres to live on a little piece of reserve that's going on today. There was no way our elders would make a deal like that. So these deals that we made that are still valid today have to be ignited again. But we have to learn about it. And that's why we're here today, trying to bring people to the awareness of the original agreements. Then you will see what the United Nations has conducted in a survey of the living standards here in Canada. We live about the third best in any place in the world, healthcare, infrastructure, economic opportunity. But when they did the same test on Indigenous communities here in Canada, that we ended up 63rd. So that is the gap that we can close realistically should we want to do that. And by accommodating our original agreements, I think we could find a path forward to that. And then you'll see more equalization in healthcare, living standards. Indigenous people are still living about 15 years less than non-Indigenous people today. We can fix that if we want to. So when I was the chief of my nation, I had these arguments with governments all day, with different leaders, prime ministers, MPs, and they all smiled and said, yeah, we're going to change that. 40 years later, we're still living in those conditions. So now, let's, at least in my view, come into the university, speaking about these things to younger minds, watching them take that out to the policies that have, neglected Indigenous perspectives. Now we'll see that change over in that manner. And hopefully that's what we tried to do, by building this knowledge base together. So that's really what our belts are here to do. And we brought out the Eagle staff this morning to signify the strength of our veterans, like Chief Pontiac, that carried the weight of the strength, and then Chief Tecumseh, and the many chiefs that came to fight for equality in this country. So as Jade is carrying this staff, it represents all those warriors who carry that strength of standing up for people's rights and to give the acknowledgement of strength. So with all this said, we'd like to close out today with that in your mind. But I'd like to say in my language, thank you, because to be able to speak to you about these things maybe you never heard about, or maybe you have, but at least it's here today on stage, where before we couldn't even come on stage and talk to you. So I'd like to say in my language, Bujo maingan and dejnakas deshkan zibi and donjaba, maingan dodem, getchimanado chimigwech minwa kukina man the ganaj when giz get nongum. Getchimanado chimigwech minwa kukina mashkiki osama, wingash, mashko de wish minwa gijik. Getchimanado chimigwech minwa kukina ningo dode mawin. So in those few words, I thought about our health, thought about the Mother Earth that we live on, to try to keep her sacred, and to live in this world in a good way for all of us to become brothers and sisters the way I think our Creator wants us to be. So with that said, Chimigwech means thank you very much for allowing us to be part of your day today. And with all that knowledge in your mind today, sit down and think about those loved ones that you have waiting for you at home, the beautiful plants and animals that you care about, those maybe who are ill. Think about something very beautiful, and then put all that perspective into your mind as you put your head on your pillow tonight and think about all you've learned today and how you can make this world a better place. So that's coming from us, the Indigenous people of this land, and we hope that you have a beautiful evening. So thank you for allowing us to be here today. Miigwech, everybody.